to all those who are here in the hall and those who are in the Martian space, the virtual world. It's a pleasure to welcome you all on behalf of the Indian Institute of Public Health, Hyderabad, which is the Southern Academic Campus of the Public Health Foundation of India. Very recently, we've moved into this campus. And like I was mentioning to Nathan yesterday, today is actually the 9th full working day since moving in. So in terms of business hours that we've had to unpack, it's still on the way. So we still have a lot of stuff in the corridors because the computer systems and all have to be unpacked yet. But we said when our colleagues, our own people with disabilities, when they face challenges in life, these are small challenges that all of us can easily surmount. That is why we said we'll go ahead on this campus rather than look at something outside as a location. So thank you very much for being here, or like I said, in the virtual space. This is going to be an exciting day and will have a lot of diverse perspectives being brought to the fore. A lot of it would look at one, inclusion, which is very critical, and two, how the digital world or digital space can actually facilitate inclusion at a faster trajectory than what is happening today. So both those are important takeaways that we'd like to have at the end of the day. We have guests from across the oceans, not just the ocean. So if it is from Europe, we can say just one ocean, but here across the oceans. And it's a pleasure to have you all here. And we would hope that you would enjoy your stay. Lovely weather, as you can see outside. 9 months of the year, Hyderabad has weather like this. Doesn't rain like this, but has weather which is very congenial. And of course, when you're going back, there's plenty to carry back for the families. Whether it's pearls, whether it's friendships, whether it's lacquered bangles, or sarees, or dress material. So this city has it all, a lot of handicrafts. Therefore, if you have the time, I'd request you to have a look, sample what this city has to offer. When we are talking about inclusion, I cannot forget mentioning that Hyderabad is perhaps the most inclusive city, inclusive metro in the entire country. And that is something we are all very proud of, the fabric which we have woven together. We are very proud of that. I now request a dear friend, Professor B.R. Shamanna, who's a professor at the School of Medical Sciences at the University of Hyderabad, which is an institution of eminence and one of the leading centers for higher education in this country, to kindly share the rest of the session and call people forward for the session. Thank you, Dr. Sham. And over to you.
Thank you very much, sir, and very good morning, everyone. It's a pleasure to be, should I say back? Yes, it's a pleasure to be back. And apparently, this is probably the first sort of a meeting which is held in this particular campus, which opened a couple of weeks ago. And thanks for the opportunity. And without wasting too much of time, I think we have more deliberations rather than introductions, etc. So I call upon Karen Barker, Executive Manager and Senior Advisor Engagement, Australia-India Institute, who actually probably catalyzes all the education initiatives between the two countries, to come up and make her presentation. Thank you.
Thank you, Professor Shamana, and I'd like to thank our host too, Professor Murty, for so graciously hosting this event, and also Professor Nathan Brill to organise the event today. I'm Karen Barker. I'm from the Australia-India Institute, which is based in Melbourne, Australia. And we're really thrilled to be partnering with you, with so many organisations today. There's actually quite a long list of organisations, and I think that's a reflection of the kind of expertise and the range of experts and expertise that we need to bring together when we're working towards new technologies and towards new directions in digital healthcare. Our work at the Institute is varied, but one of the key things that we do is support the bilateral education relationship between Australia and India. And for that, we're generously funded by the Australian Government Department of Education. So I'd like to thank them for their support for this event today as well. Key to government is research collaboration between Australia and India. It's a real focus for both governments at the moment, is to promote research collaboration. And just a couple of weeks ago, the Indian Education Minister, Minister Pradhan, visited Australia to meet with his Australian counterpart, Minister Clare, for what used to be an annual meeting of the Australia-India Education Council, disrupted a little bit by the coronavirus, but reconvened recently. And at that meeting, both the ministers reiterated their commitment to deepening research collaboration between Australia and India. And they also launched 2 programs which we are delivering for them. And I just want to briefly mention a little bit about two of these programs. One is called Arch India, and Arch stands for Australia Researcher Cooperation Hub India. And it's a virtual platform to encourage researcher collaboration between our countries. It asks researchers and research students to register their profiles on the website and to indicate whether they're open to collaboration, and to encourage contact between researchers for that exact purpose. And if you're new to collaborating with the other country, we've got a mentorship program that's part of that virtual platform, and you can find a mentor who can help connect you to the right person for you to talk about a collaboration. The other reason the website's so important is because it's got a lot of resources on it, and that includes a list of funding and grant opportunities. And these are sent out in a monthly newsletter. I'd like to thank my colleague, Brina Barrett, who puts together that monthly newsletter. So I encourage you all to sign up, and we'll be sharing the URL, the link with you, so you can do that easily. One of the things we're going to be advertising on Arch India platform is a new program called the Australia-India Research Students Fellowship Program. This is a program which the Institute is developing for the Australian Government Department of Education, and it's going to be offering up to 70 fellowships for research students and early career researchers, so people who've got a PhD within the last 5 years. So master's students, PhD students, and early career researchers will be able to apply for these fellowships. We're reserving 35 fellowships for Australian students to come to India, and 35 fellowships for Indian students to go to Australia for short-term research. And you can do the research towards part of your master's program or your PhD program, or you might be writing a journal article. So the research project doesn't have to be tied to your current course, but it can be. And so we're hoping to open for applications later next month. So we'll be advertising that in the Arch India newsletter, and I would encourage you to apply or promote it to your research students who you think might be interested in short stints in Australia or in India. So these fellowships will run from, the minimum period will be 4 weeks and the maximum period will be 8 weeks. And we're fantastic to see full take up of those 70 fellowships that will be on offer. Today, however, it's all about health and inclusive digital health and the technologies needed to make that work. So I don't want to take up more time. I want to give that over to the discussions, and I wish you all the very best productive and fruitful discussions for today. Thank you.
Thanks, Ms. Barker. I just want to summarize very quickly the sort of pointed initiatives which you mentioned in terms of driving bilateral education initiatives, and in the context of research collaborations. You talked about Arch India, and I don't think so. It could have come at the right time in terms of a lot of opportunities being open to students both ways. So Arch India and the Research Student Fellowship, and 70 fellowships, 35 in each country being offered to early career researchers. That's phenomenal. And as indicated, I think the website will open up, or the initiative will come up in a week's time or a month's time, or by the end of this month. So please look out for it. We're very happy to have both early career researchers here, as well as sitting down in this sort of room here. So it's my pleasant duty to call upon Professor Mckerbin, Deputy Dean, Faculty of Medicine, Dentistry and Health Sciences, University of Melbourne. Mike probably would take us through the digital future of healthcare, and with relevance to the reflections from the University of Melbourne. Thank you, Mike.
Good morning, everyone. Thank you, Professor Shamana. Can I have my presentation? Okay, so thank you. And I must say at the outset, I'm not a digital health specialist, and what I'll be doing is giving you a perspective from someone who is involved in helping to guide the research strategy across our broad and large health research faculty. And I'll make some, how can I change these slides? So what I'll be doing is just pointing out some of the challenges, I guess, in this field, and some of the things that we need to do. Tell you a little bit about a Centre for Digital Transformation of Health that we've set up in the faculty, and then use some examples of people that are implementing digital health solutions from our faculty and the challenges that they face. And, solving major health challenges increasingly is requiring multidisciplinary approaches to tackle those problems. And we, wherever possible, are putting together teams across disciplines, our clinicians, our fundamental basic science researchers, but also with engineers and IT specialists, with government, with industry where necessary, to try and tackle these problems. And of course, there's a lot of hope that digital solutions can increase the efficiency and effectiveness of healthcare, and importantly, address health inequities by improving access to people, including with disabilities. So I'm really looking forward to hearing about some of those today. But where are we at the moment? There's a plethora really of digital health solutions that have been created by researchers, but also by sort of non-experts out there. Many of these are reasonably poorly developed and not really subjected to rigorous testing. And lots of these interventions fail to get really implemented into healthcare. So we've got to find a better way of ensuring that, our digital health solutions are created in as high quality a manner as possible, and that we test them appropriately and take a lot of care about how we implement. And there's lots of barriers to implementation. I'll put some of them down there. The barriers around data sharing. In Australia, we've got, multiple health levels of the health system, and the data doesn't necessarily talk to each other. That creates problems. There are privacy issues. There's uptake issues around the clinical disciplines and clinicians, being a bit apprehensive about changing their practice and perhaps losing control and even losing funding for the work that they do. And then there's community awareness. Does the community know that these things are available to them and take them up? And there are, do you commercialize these things? Do you make them free? How do you make it available? How do you make the system work? So if what we've got here is a sort of comparison between the drug development process that many of you are probably familiar with, where there's a very well sort of documented pathway. It's tortuous. Lots of things fail as they go through this pathway. And in fact, failing fast is a kind of mantra in drug development to work out whether something's not going to work and stop that in the pathway before you spend too much money in it. It is tortuous. It is expensive. But in digital health, there's a kind of a bit of a black box in the middle about how do you take something through a pathway and make sure that it's ready. And it's at least a formal possibility that some digital health solutions could cause harm. And so, we shouldn't underestimate how rigorous the testing of these things should be. So we've set up a Centre for Digital Transformation of Health. Hiding under that little thing there is Wendy Chapman, who's also, as well as the head of this centre, just lifting the microphone a bit, is also our Associate Dean for Digital Health. And the purpose of this centre is really to try and bring together all the pieces of this system and be a central point for researchers, but also interact with patients, with healthcare professionals and upskill them in digital health, but also with government, with educators. And this centre is actually a joint centre between our Faculty of Medicine and the Faculty of Engineering, where the computer science expertise is in there to sort of develop the digital parts of this solution. And importantly, this centre is setting about educating health professionals in our healthcare partners to bring up their digital skills. And Wendy is working on something that she calls a learning healthcare system, where problems feed in. You try and find digital solutions, analyze the data in the background, develop new tools that might be required to implement those solutions, and then drive, importantly, in the implementation phase, the necessary behaviour change and adoption, either in the clinical setting or the community setting. But importantly, that this is a sort of continuous improvement loop where you keep learning, testing, evaluating, and improving your system so that you keep optimizing. So that's the sort of concept around which we're trying to build digital health solutions. And I'll just switch now to talking about a few examples. Hiding again behind the top of the screen there is Mario Alvarez. He's a clinical psychologist from our Centre for Youth Mental Health and Origin. And he's very focused on digital health solutions for young people with mental health issues. And that stems right from prevention through initial diagnosis and treatment through to continuing care for those patients. So he's working on digital solutions across that sort of spectrum. And I'll tell you about one which is being implemented across a large part of Australia now, and that's called MOST, for moderated online social therapy. And this is a tool aimed at youth, so people 12 to 25 years of age. It gives them access to evidence-based therapy that comes with some face-to-face clinical support, but also with online tools. And the therapy is really tailored for the individual patient. And so this is an online platform, but it does involve interaction with clinicians. And its clinical rollout was initially funded by a $6 million grant from the Victorian government, boosted by $1 million from a foundation. But it's now being rolled out through our Headspace centres in Queensland, and now New South Wales and the Australian Capital Territory are going to roll it out. So the whole sort of eastern seaboard of Australia is rolling out this platform. And for Mario, this has meant in just a couple of years, he's moved from a sort of research and development phase with a team of about 20 And now he's got about 120 people delivering this platform. And you can imagine the challenges that he has at the moment in implementing this. Every new clinic that they put on has to learn how to use the technology and interface with the patients correctly and sign them up. So there's a whole lot of continuing education that has to go on from this team, plus all of the sort of online clinical support that goes on. So he's got a bit of the speed wobbles, probably, he might admit it, but you know, that's a challenge for him rolling this out. But it's a good example of being able to take a digital solution into and supported by the health system, by government, to implementation. This is Alicia Spittle. She's our Associate Dean for Research. She's a physiotherapist who's interested particularly in disability in premature infants, particularly in cerebral palsy. And she's developed an app called Baby Moves, and you can see there a picture of a parent filming a young baby at home. And this app provides an interface where this can happen. And then Alicia and a team have developed algorithms that can monitor the movements of these babies, and they can detect cerebral palsy in babies less than 6 months of age. And this opens up a window where there's still neuroplasticity and brain development going on, where there's the possibility to improve the lifelong outcomes for these infants. And this is concentrated on premature babies who are at a 20-fold higher risk of developing CP. It's a program that at the moment has been supported by research grants, both in the development phase and now in a wider testing phase, but it needs to, move into a system where it could save the healthcare system a lot of money down the track, but who's going to fund it now? It does at the moment require some interaction, and they deliver actually some counselling support for these parents who are really worried about outcomes for their children. So there is a face-to-face element for this, but it could work in a way in which there wasn't any face-to-face contact, and you still have the parents filming the babies and be a fairly low-cost intervention. So that's at that sort of interesting phase where can it be taken up and will it move further forward? And the last example I want to talk about comes from Professor Mark Cook, who's epilepsy researcher, neurologist, and he's developed a couple of technologies which are improving the management of patients with epilepsy, and he's commercialized those. So that's one option that you can take, and he's commercialized both something called EpiMinder, and you can see a woman here wearing a device, and that device monitors her brain activity and can predict seizures. So there's continuous monitoring that patients can have, which of course gives them a whole new sense of security. But he's also developed another company, Cia Medical, which does at-home monitoring of patients with epilepsy. And this is something that's normally done inpatient in the hospitals. And so far, they've helped over 10,000 people through this, and they've shortened the waiting time in hospital for this assessment from 6 to 18 months to 6 to 8 weeks. And if you just take 2020 as an example, they delivered 25,000 home monitoring days and estimate that that saved the hospital system $50 million. And this is all embedded in a company that's delivering this for the health system cost effectively in a commercial manner. So what can someone like me and our faculty do to try and help people successfully implement digital health? And the sorts of things that we're trying to do is to provide high quality technical support in the development phase. So the Centre for Digital Mental Health will help with that, help organise people into appropriate multidisciplinary teams, provide support through the centre, but also through a hub we call MISH, which provides clinical trial design support to ensure that there's rigorous testing in the development phase, and then help people navigate this pathway about how are they going to implement this in the end. Do they need health system support? Do they need health insurers on board? Is it a commercialization prospect? Is there an industry partner that they could work with? And how do they interface with consumers and ensure that this is what the consumers want and will be advantage from. So I'll stop there. Thank you very much for the invitation to speak, and I look forward to today's session. Thank you.
Thanks very much, Mike. I've been informed that the proceedings of these deliberations have been recorded, and that's just to take your consent in terms of, you don't have any objections. And my request, Dr. Murthy, to hand over this before I call upon the next presenter, Professor Murthy. I think Mike very nicely summarized the work which was happening at the University of Melbourne. He mentioned particularly about 3 initiatives with respect to, the MOST, which is for youth mental health, and the baby moods, which is for early diagnosis and care for children with, kids with cerebral palsy, and the Epiminder and Seer Medical, which was to do with, the monitoring and management of epilepsy, and particularly institutions getting into technical support, trial design, including health economic evaluations, and, the pathways from bench to bedside to brass tacks, if you want to call it, in terms of what support we could provide. It's wonderful, Mike, and we will have a couple of questions at the end of a couple of more presentations. But a couple of questions which probably you may look at is the whole aspect of end user engagement when it comes to development of health technologies, and not to forget the security and privacy issues with respect to digital health. And I think we'll talk about it later. Dr. Murthy, can I come in and can I ask you to come in and present about the experiences of inclusion in digital health, especially during the pandemic? I don't have to introduce Dr. Murthy, he's been my guru. So,
thank you for that, Dr. Sham. Thank you, Chaitanya, for that, because we have many more people online, and therefore to see that they are able to see the presentations is very important. What I'll try and do is give you a very brief idea about what has been happening mostly in India, and trying to look at evidence which enables us to look at why digital technology is very important when you're looking at inclusion. Now, I'll try to very briefly look at some of the work that we have done as part of a situation analysis of the difficulties faced by people with disability during the pandemic. Some of the work that we've done in terms of reaching out to people, including people with disability, through the digital space. I'll touch briefly upon some of the digital solutions that have been developed, and we have presentations later in the day from colleagues from the L.V. Prasad Eye Institute, from St. John's Medical Academy. We'll try and look at their own experiences of what actually they found when using digital technology in relation to inclusion. Finally, the need to take this forward. So I'll look at a couple of studies that we did. One was very recent, in fact, published just the day before yesterday, looking at people with disabilities across 14 states in India, and looking at them at 2 points. One, during the pandemic, when the lockdowns were being affected, and then immediately after the first lockdown was lifted, to see if there was a change in their perception in relation to their problems. So we found that a significant proportion, that is 82%, reported moderate to severe stress levels. And this is something that we need to look at when we look at finding digital solutions. More than half who needed rehabilitation services couldn't access. And this was, I think, something which not only for rehab, but even for general health services, for the rest of the population was also a problem. But for people with disability, therapy is critical, and we find that therapy was badly affected during the pandemic, the lockdowns in India. And more than half, they reported having problems in accessing healthcare. And this seems to be a higher proportion than what the general population has reported in relation to access to healthcare. Again, looking at the same study and looking at that entire 403 persons with disability, you find that amongst those who had a need for emergency care or needed surgery or outpatient clinic services, needed medications, or needed mental health information, in all of them, less than 50% of those who actually needed those services were able to avail that. And that is a telling story, that we need to look at things differently, do things differently if we have to look at including persons with disability. And the proportions may seem small, 5% needing surgery, but out of that, if 50% could not access because of the lockdowns, then that is something we need to keep in mind as to how we can improve the future, at least in terms of some of the consults, if not surgical procedures. The same study again, about 12%, 12 to 13% of people with disability had pre-existing health conditions. And this is not the primary impairment. I'm looking at the other health conditions that people with disabilities face. And again, 58% had problems in accessing healthcare. 25% had difficulty in getting medical supplies. And they ran out, they didn't know where to get these supplies, and they had to postpone their scheduled visits. We all know that persons with disability have a higher prevalence of non-communicable diseases, and they need things like routine care, like monitoring blood pressure, but nearly 60% obviously could not reach this. And this is something which digital space can actually make a difference. There were apprehension. They did not want to go to hospital. 3 out of 4 people said, we are scared to go to hospital because we'll pick up infections. And 86% were scared to meet people outside their family. And even for the rest of the community, I think similar apprehensions were there. But for people who were visually impaired, people who were hearing impaired, these apprehensions were even more than the general population. The lack of companionship again came out as a very important thing. And this is again something digital world can make a big difference. So we find that there were certain apprehensions, certain problems that people with disabilities faced across 14 states in India. If you look at the study learnings, I look at, again, for most of these learnings that we had, persons with disability tailored hygiene practices. That was missing. And that can be done through the virtual sphere. Online counseling and mental health support, teleconsults, which one of my colleagues, Dr. Vipin, would present in relation to eye care. But this was something which came out as doable. Information in accessible formats, rehab. The only thing which perhaps the digital world may not be able to directly, but can facilitate, is the doorstep medical supplies. So if you look at a lot of these learnings, many of them are amenable to digital technology. We also did another study called the Covet Collective Study, which is a multi-nation study coordinated by the London School of Hygiene and Tropical Medicine. And this was across 6 countries. In India, we were coordinating the study, and a lot of my colleagues standing right at the back, so obviously she's visible to me, is Dr. Gauri Iyer. But there are many other colleagues, Dr. Nan Kishore and all were here. And we again did it in 2 rounds. One during the initial phase, not initial phase of pandemic, but initial phase of lifting of the lockdowns. And then later on, that was last year, we repeated these interviews with nearly 75% who were contacted in the first round. The problems were very similar. Exclusion in decision-making in relation to the COVID response. I think that's something we need to keep in mind. The knowledge of preventive methods, prevention strategies, very poor knowledge. And those who are hearing impaired, the use of masks made it doubly difficult for them because they could not lip read any longer. Communication guidelines not available in accessible formats. Vaccination. So in India, to get a vaccine, you had to register yourself. So a person with disability had to depend upon somebody else to register them for getting the vaccine. And most of the vaccine centers were not accessible centers. So it was difficult registering and difficult getting the vaccine. Health access, because of reduced clinic hours during the pandemic, again was a challenge. And in relation to telehealth, in the second round of the interviews, we found that the use had increased. A lot of the caregivers were now oriented to using telehealth techniques, and therefore they felt that this was a way to go forward. Therapy and assistive devices. The loss of the ability to go out of the house had an impact on simple things like batteries for your hearing aids, and therefore people could not use them. So assistive devices, maintenance was affected, and therapy was very badly affected. I look at some of the other studies, very small studies, but just to set the context. So this is in Puducherry. The Arvind Eye Hospital looked at finding out perceptions of people who are blind or visually impaired. And they found that the blind were more concerned about access to healthcare, and their information on COVID was very poor. In fact, they perceived that COVID was a risk factor for them going blind. And therefore, this sort of information which needs to be provided and be available out there was not there. Most of their information was word of mouth, and the risk behavior of not using masks during the pandemic was much higher. The hearing impaired, again, another review of studies in India, again points to the lack of adequate accessible information. I talked about the difficulty in lip reading and maintenance of assistive devices. This came out of the study. And for the hearing impaired, telehealth access was limited because of their inability to access something which is talked, which is verbal, and therefore not accessible to them. So this particular paper brings about the sort of disparities that the lockdown brought about for persons with disability. And I would look at the last one here, which looks at the digital divide. And this is something that when we are talking about inclusion, this digital divide is something that we need to look at. In addition to finding solutions to the other problems, the digital divide has to be bridged. Just a few examples of what we've done from this institution. We've used tele-ophthalmology techniques for diabetic retinopathy screening. This is, of course, people who have mild to moderate vision impairment and not those who are blind, because then they would immediately go into the treatment arena. So this was the digital technology using to capture information at the primary health centers and the community health centers where people were screened, and images were transmitted to a base hospital across 10 states in India, one pilot district across 10 states. So that was prior to the COVID pandemic, but we already had started moving in that direction. More recently, with support from USAID and one of my colleagues, Dr. Rajan Shukla, he is spearheading this project of using tele-ophthalmology for retinopathy of prematurity. You mentioned, Mike, about the preterm cerebral palsy screening. And this is again very important, because if you do not pick up retinopathy prematurity early, children would go blind and lose vision. And therefore, we looked at training nurses in the special newborn care units, where they're the ones who are primary carers in the hospital. And they then take the image using these cameras here and transmit these images to a base hospital where the reading is done, and children who need to be treated are immediately scheduled for laser treatment at the earliest. And this is something which started during the later part of COVID, and it's still going on in the states of Telangana and Andhra Pradesh. Another colleague, Dr. Suresh, who works on stroke. So he developed this app called the Care for Stroke app. This was developed before COVID, but during COVID, we still went ahead with the clinical trial, looking at early rehabilitation of patients who've had stroke, using this app to help them look at exercises, look at eating and feeding, etc. at home. So this is another thing that we have done recently. So these are things which we have experimented with, but they are just the tip of the iceberg. So if you look at the needs, we are aware of the fact that there is an increased risk of disease and complications during a pandemic for people with disability. There is a delayed and restricted access to services, including limited hospital access. And this is where they could be better inclusion if you look at the tele world. That's through teleconsults, through follow-ups, rehab, tele-supported rehab, accessible IEC, or telecounseling. So let's look at this. Our health system in India is normally overloaded. There's a high case load, so the horse can't take the load. There's limited access, affordability an issue. And when there is limited access and affordability an issue, the people who suffer the most are persons with disability. And therefore, to have a more level playing field, having in-person care synergistically balanced with digital healthcare may bring about inclusion of persons with disability with outcomes which are far better than what we have today. I looked at 10 different aspects where digital health can actually make a difference in relation to inclusion for persons with disability. Starting with the identification of the population that is in need of these services, to monitoring whether they have received services, screening for complications to prevent further outcomes which are adverse, surveillance, information, education, and communication to bring about a behavioral change, counsel, treatment advice, rehab, capacity building, especially of parents and those who are primary caregivers of persons with disability, providing counseling support and follow-up. So these are not exhaustive, but these are very critical 10 elements which I thought would make a big difference. So what have we seen recently in relation to inclusion? Tele-ophthalmology is perhaps one of the first off the blocks, and a lot of inputs have been given, and Dr. Sarah would mention some of that. I would not go into that in detail, as well as Dr. Vipin. But if you look at what is happening, most of the people who receive the teleconsults, there is no way to make out whether they were visually impaired. So what proportion of the visually impaired or people with other impairments actually use the consults is not known. And therefore, if you're looking at inclusion in the monitoring indicators, to look at this aspect is very important. Another thing that came out through this study was that most people, 3 out of 4, depended on the audio link rather than the video link, and they were more comfortable with that. But 90% could upload images of the external eye without any problem. But there was a literacy constraint. And when you're looking at people with disability, literacy is lower than the general population. And you have to fill up a form. So it means that some amount of literacy was important. And most of these teleconsults for a red eye or for conjunctivitis or watering of the eye, so they were basically for the non-blinding or non-visually impairing eye conditions. Tele-rehab, I think, is one area which has grown tremendously in the last 2 years. And this again is at L.V. Prasad Eye Institute, looking at visual rehabilitation using the teleportal. And all these people were either blind or were severely visually impaired. 42% were children with vision loss. And what they found was that this was a good way of reaching out, but there were challenges. The major challenges included poor internet connectivity, orienting parents to technology use, and motivating parents for using tele-rehab, because in their own perception, parents felt that a physical in-person rehab model was something that they were more satisfied with, seeing that something was done to their child. So there were concerns, but these are things that could be easily addressed. Also looking at the provider's perspective. So we had students with autism and other learning disabilities, and their carers, their therapists being interviewed about their perceptions. They conducted both direct sessions and parent mediated. So both models were used. What this particular group saw was that all the targeted benefits that they wanted were maintained, and that 52% students acquired better skills with tele-rehab than with in-person. So there is the jury is out. There is a debate going on, but definitely digital technology in relation to services for people with disability can actually make a big difference. And this is with pediatric tele-rehab. Adults is different, children it is different. But even here, we find that when we talk to therapists, the providers, they still have a mixed feeling in terms of whether they should go forward with tele-rehab. So nearly a quarter had no previous exposure to teleservices, so they were a bit hesitant. And 85% preferred in-person consultation. That was more in their comfort zone than in the tele-rehab zone. They felt, a significant majority felt that the teleservices may perhaps reduce the quality. So these are perceptions which we need to fight to actually make a difference as we go forward. But at the same time, nearly 60% felt that patients or parents saved time if you had a tele-rehab portal. So these are important learnings for us to go forward. This is just a graphic illustration. This is not numbers. So if I look at what has happened from April 2020, the beginning of the lockdowns, the initial experimentation was with consults, teleconsults. They started increasing, and over a period of time, within a year's period, that actually came up very strongly. Then accessible information technology, communicating messages, that started increasing. Then rehab, some of the examples that I have just shared, a bit on the follow-up. But if you look at those 10 themes where we can actually make a difference, if you look at it, still a lot of work needs to be done. The trajectory is slow. We need to pick up pace and look at it being more comprehensive, so that all the other areas where digital technology can play a role can actually be brought to the fore. But most important for us, when we're looking at whether inclusion is working, is to have disaggregated, stratified analysis by disability. And that is what is going to be important to measure inclusion. If we don't do that, we don't know whether we are reaching persons with disability. Are they getting included? Or are we only reaching those who could have otherwise come to an in-person consult, but felt it more comfortable staying at home. And this, I think, is very important, that we need to look at the disaggregated data. Before I end, one vignette. And this vignette is very powerful because it comes from a person who works in the disability world, who's an admin officer, or the reception looks after all the calls, or the admin related calls at one of the leading disability organizations, disability and development organization in the country. And these are her perceptions, her concerns of what she faced during the pandemic. I did not have contact with any colleagues for a long time. These are in her words. Work from home was declared on 23rd March. So I had to go home with just the laptop and a dongle. Though I am the voice of the office, I became absolutely unspoken these days as lockdowns kept getting extended. Being a person with visual impairment, I couldn't get out of the house to even the gate for even walking or buying any stuff. It was frightening because whatever I touch or wherever I touch, knowingly or unknowingly, I was scared of the high chances of being infected. Though I'm married and I have a 15-year-old kid, I started feeling lonely at that time. On the other hand, my son's online classes started. We didn't have a personal laptop or an Android mobile phone. So that became another challenge. The whole of 2020 worked from home for me. And from March to the end of September, every minute for me was a nightmare. For us, when you're looking at inclusion and digital technology, there are three major points here. One is providing accurate information, providing information in an accessible format, providing mental health support and counseling support to a person who has been working for more than 20 years in the disability world. This is a perception. And therefore, I think we need to look at inclusion and digital technology coming together. Thank you very much.
Thank you very much, sir. I think in India, we have this thing called as IST, Indian Standard Time. We are stretching it a little bit. We'll call it Indian Stretchable Time. We'll curtail the tea break a little bit. I think just to summarize the presentation in one sentence, whether it is health technology for others, or whether it is digital health, or whether it is anything to do, this parlance of what is called as nothing about us without us holds good. And hence, I think it's very important that whenever you look at these initiatives, you also take into consideration the perceptions and the viewpoints of persons with disability. So that is what I would say based on all the experiences which Professor Murthy presented. And a question probably which arises is using digital technology and social security net for persons with disability. That probably is a very important aspect related to it. So the next presentation is very interesting. Many of you would probably know about eSanjeevan, which was a very, a landmark sort of an initiative within the country in terms of healthcare. And we have Dr. Sanjay Sood, who heads, the eSanjeevani initiative based at CDAC in Mohali, and also probably, has done phenomenal work with respect to making sure that the use of, eSanjeevani platform has been phenomenal. I would request Chaitanya to probably connect to Dr. Sood and play the presentation. Thank you.
Thank you very much, Chaitanya ji. Good day, all the participants. At the outset, I would like to thank Professor Nathan Grills, Professor Murthy, Professor Mike, Professor Shamana, and Professor John Oomen for putting together this event and giving me this opportunity to talk about eSanjeevani, which has scaled to mammoth size, and we being on the other side of the delivery, that is at the back end of this telemedicine platform. So I'll be more talking about the platform, and then we'll be giving some sort of an expose that how eSanjeevani is now gearing up for being a platform that could be that could sort of enhance the accessibility, inclusivity, and equity further to include beneficiaries from all stratas of life. Next slide, please. As far as eSanjeevani started, we were directed to put in place the platform, which was originally meant for doctor-to-doctor telemedicine consultations, but owing to the pandemic, as soon as it struck the Indian shores, the Ministry of Health and Family Welfare wanted eSanjeevani to be transformed to a platform which could provide patient to doctor or doctor to patient connectivity in a remote sense or virtually. And hence the telemedicine practice guidelines, those were released in March 2020. Then of course the pandemic, and I mean, these two were actually the drivers which enabled us to quickly or rather rapidly put together the platform or customize the platform, which was originally a doctor-to-doctor kind of a, or a provider-to-provider kind of a telemedicine platform. We customized it and put it in place to enable the patient-to-doctor consultations. And the platform, the key guidelines or the philosophies, those were shared by the Government of India, were that it must be a citizen-centric platform, it must be secure, it must also replicate or mimic the traditional OPD in the hospitals, because this was probably the first instance in the country that the patients would be using virtual healthcare to get access to health services. And the same was true for most of the clinicians as well, or the practitioners as well. Accordingly, in April 2020, we rolled out the desired version, and to our surprise, or rather, we were happy to see that it suddenly attracted all the traction, and very soon, almost all the states within 2 months, all the states had rolled out eSanjeevani OPD online OPDs, which had started extending services remotely to the patients in the confines of their homes. And based on the necessity, it was further felt by the state administrators or health administrators and policymakers in the states specifically. Originally, eSanjeevani was meant for a very simple, one OPD per state kind of a mechanism, but because of the quick adoption and the potential that the telehealth holds, or people could realize that it is the only medium for them to connect with the doctor, and the same was correct for doctors, that they also realized that this was the safest medium for them to connect with the patients and ensure that they could remain healthy and treat as many patients as they could while being healthy without falling a prey to the pandemic. So we received numerous requests and numerous suggestions from the policymakers in the states, as well as the nodal officers who were managing eSanjeevani in the field. And based on those requests, we have been continuously evolving the platform, making numerous changes depending upon how and what was required in the states. Accordingly, in I think less than 7 months from the launch, before the end of 2020, from just about one OPD per state, that is around 36 OPDs, online OPDs for every state and union territory, the number of OPDs increased to more than around 800 OPDs online. And these were now offering services which were not only general medicine, but they included specialties, super specialties, and then the best part to realize was that we also opened online OPDs for state governments, which would serve the patients or the inmates in correctional facilities, old age homes, and orphanages as well. And then the last of all to onboard this particular platform, of course, was the institute which has recently gotten on board. It is the All India Institute of Physical Medicine and Rehabilitation, based out of Mumbai. They themselves came up and requested eSanjeevani to open online OPDs for their patients so that they could carry on with the rehabilitation of those patients who were not in a position to come over to the institute. And this was more like the first step that eSanjeevani experienced towards increasing the inclusivity for people who are specially abled. So that is how the platform got bigger and bigger. And next slide, please. And in a way, based on the popularity of eSanjeevani OPD that is depicted on the left side, we could see that it was basically the regular cadre doctors and also the doctors who were specially appointed for telemedicine purposes in various states. And this particular slide belongs to the schema shows the UP's scenario, wherein the 5 medical colleges had appointed a group of doctors specifically as telemedicine practitioners. They were also offering health services to patients. And inclusivity for the populace in the beginning meant just about those who were either IT literate or had computers and PCs at their homes, or who were smartphone users. But then the state authorities did want to include people in the rural areas who did not have smartphones or neither were IT savvy. Sorry. Accordingly, in those days, the health and wellness centers were also not fully functional. So the states came up with an idea of having a provision made in eSanjeevani, which could eSanjeevani suggested us to put in place a mechanism where the community health officers or the health workers, including ASHAs and ANNs, they could also be provided a login there within eSanjeevani OPD, and while they go from door to door, they could extend the service through their tablets which they were carrying with them. So this was another innovation which increased the inclusiveness of the population, which otherwise, or the section of the populace which was not otherwise having access to IT or internet services. So they were also onboarded by enabling the access of doctors through eSanjeevani OPD through the health workers who would be making rounds in the locality door to door, and also check with the families in case they would want to consult doctors, and they would facilitate those consultations. As the COVID got stabilized, or the COVID got under control, eSanjeevani Ayushman Bharat Health and Wellness Center, the original variant of eSanjeevani, which was meant to enable doctor-to-doctor consultation or provider-to-provider consultation, was strengthened, and we could then put it in place. Earlier, it was a data center based model, but then because of the scalability, we had to put it on cloud. So we sort of enhanced the entire application and rolled it out somewhere in the middle of 2020. And since then, next slide, please. And since then, we have seen that this particular variant has suddenly increased the uptake of telemedicine, because this is the variant which has actually led to the inclusion, or rather enabled access of rural populace or isolated people living in isolated communities to specialized healthcare services. So if we can see the orange parts in the graph, in the bars, they reflect eSanjeevani OPD. And this was until December 2020. And it is actually from December 20, the health and wellness centers picked up, and suddenly it has scaled up to an extent that we've now enabled eSanjeevani health and Ayushman Bharat health and wellness centers variant in over 102,000 health and wellness centers, wherein the entire platform collectively is being used by, or is being accessed by, health workers and clinicians and community health officers and specialists. And these are around 208,000 in all. And now eSanjeevani is doing over 250,000 consultations every day. So that is the scale at which it has grown. And this is primarily because of the inclusivity that has come up for the populace, which otherwise was left out of the digital health ecosystem in the country. So eSanjeevani is making a great effort to plug the digital divide that exists between the rural and the urban populace. And that is how we are working towards making it bigger and bigger. And currently 85% of the consultations are happening in the rural areas. And the clinicians, 102,000 spokes or health and wellness centers are served by around 12,000 hubs, which are populated by specialists and super specialists. And the states decide which specialties would be served through these hubs. So depending upon the specialties, each spoke is connected to at times more than 2 or more than 3 hubs, which are available. The services of the specialists are even available. As per a study conducted by an independent research agency in the state of Jharkhand, they have sort of found out based on the survey done with the beneficiaries there that every teleconsultation happening on eSanjeevani is enabling a saving of up to rupees 2,000, which is something like I would say sizable dollars, 25 or something like that, dollars, which are being saved per consultation. And similarly, each teleconsultation happening on this doctor to doctor or provider to provider variant is also leading to a saving of a journey amounting to around 18 kilometers, as they've found out. Next slide, please. So this is how entirely eSanjeevani is trying to mitigate the challenges. The first challenge that eSanjeevani was trying to address is the accessibility to health services for just about anyone in the populace, and that to a significant extent has already been addressed. We can see by the trend that we saw on the previous slide that eSanjeevani is able to reach out to just about every corner of the country, and it is being used in the rural areas specifically, as 85% of the consultations are pouring in from that platform. And during pandemic, when the first, second, and third waves, the other variant, eSanjeevani OPD, was significantly popular, and we've been serving more than many OPDs which were centered around the COVID care part, the screening, and then the quarantine patients, etc. So they were more into COVID related ailments. And currently the eSanjeevani OPD variant is serving 15% of the total patients who are showing up on eSanjeevani's bigger network. And we ensure that we train community health officers, practitioners, and even the state nodal officers by running virtual trainings. And it has all been end-to-end virtual ecosystem, starting from the design, development, deployment, operationalization, maintenance, and also capacity building of just about every stakeholder in the value chain. And we have also put in place, or rather institutionalized, the the arrangement at district level, and even in some states it is working at the sub-district level as well. The district nodal officers are having multiple sub-district level nodal officers, and they are then coordinating with each other to ensure that the utilization is good and the challenges are met, and they convey to us the challenges which are being faced by the users. Very recently, we had visited the field just to sort of look for ourselves or interact with the users of e-Sanjeevani in the rural areas, and we visited places around Uttar Pradesh, which is supposedly a large North Indian state. And we could see that we had hardly gone around 50 kilometers from the capital Lucknow of that state. And we were assuming that the place would certainly be better than the deeper health and wellness centers, which are deep in the rural areas or isolated communities. But to our surprise, the challenges faced by the users there have been majorly centering around the internet access. The internet services were not all that good, even 50 kilometers from the state capital. And the second challenge that they faced were the shortage of specialists. So these are the two challenges which we felt are the biggest challenges as of now. And as far as the patients are concerned, the health workers and the community health officers convey to us that they are fine with the services those are being provided. They are getting used to it and they are getting familiar with digital health. And as a result of which, yet we did specifically talk about the accessibility part of it, and they have been supporting them. And I mean, independently, people, especially abled people, have not been able to use e-Sanjeevani, but they say that they come along with their attendants and they are able to sort of consult doctors with the help of the attendants who from the family who come with them. So that is the medium as of now. But we are, next slide, please. We are working towards the mechanism which helps us to understand that how how the users want it, what are the problems and issues being faced by them, and then we work towards the technical teams or assistance which is available in the state in the form of international or national development agencies like GIFIGO, PATH, and various other agencies, and they help the workforce in the states and the rural areas as well to build their capacities as well and to handhold them. And then we also from time to time interact with them, of course, virtually, and look for the suggestions and the requirements that they have, newer requirements and additional suggestions. So we keep on customizing e-Sanjeevani based on these requirements. And I would say that from the day we rolled out e-Sanjeevani on 13th of April 2020 and the model that is existing now, there's a lot of difference. There are multiple dimensions those we've added lots of few diagnostic devices as well, which are seamlessly integrated with e-Sanjeevani. We have enabled the printing of the prescription on a 80 mm strip printer, those POC kind of handled devices. And then we've also put in place mechanisms wherein the patients are not having smartphones. We are sending the prescription. We are sending the prescription to the patients as a SMS to their on their feature phones. So these are the kind of changes, and these are the kind of innovations we are doing. In a couple of states, the medicines are also being dispersed, or rather dispatched or delivered seamlessly. As soon as the prescription is done, the prescription lands in the warehouse of the locality of the patient, and the medicines are packed, and the medicines are then delivered by the health workers on the next morning when they go for rounds in the locality. So those are the kind of interventions. Next slide, please. That we are working towards, and as far as the newer dimension, which with the courtesy of Australian government and the Indian government, we are now looking up to in a big way, is the inclusivity for especially abled people. And we have been making efforts, or we have been in discussion with WHO and WHO ITU's teams, wherein they put in place the global standards for accessibility of telehealth services. We have been discussing with them now that eSanjeevani 2.0, which is a revamp of entire eSanjeevani, it will be a unified eSanjeevani with two applications, single application having two front ends and one back rear end. It will enable higher productivity of doctors, so they don't have to manage two applications. It will be from within the application, they'll be able to practice on both the variants. So that is how we are also ensuring the tele follow-ups and tele referrals, which will be part of it, and multilingual approaches. And as of now, we've not incorporated the Government of India's, there are Government of India's guidelines for websites, and they have certain element of those GIGW guidelines. They do have certain element which touch upon the accessibility part. For example, people with shortcomings in terms of visibility or hearing, etc. They do take care therein. Some of them have been incorporated in eSanjeevani as of now, but in a big way, we certainly will now be looking up to to Professor Grills and his team, and also other stakeholders like maybe IIPH as well, because they have very rich experience of the managing the users on the other side, that is in the field. So we would look up to these, I would say, champions, and seek their support in putting in place mechanisms which will help eSanjeevani to be good for people who are specially abled. And we are also working on certain standards which have been released by BLAS. And there are a couple of standards which also have some overlaps with these global standards, as well as the virtue care model. So we'll be very eagerly looking forward to have eSanjeevani 2.0 compliant with to these standards. And next slide, please. With this, I thank you all for sort of giving us this opportunity to talk about eSanjeevani. And this is some of the models which are followed by specifically UP government, wherein they provide incentives to the doctors and also the community health officers for practicing telemedicine. And that is how the states and the administrators are helping telehealth to grow in a big way in the field and serve the populace. Next slide, please. Thank you so much. And I would once again acknowledge the contribution of Japaigo for giving us some material in this presentation. Thank you very much. In case you would have any questions, I'll be available, and maybe at the appropriate time, we'll be happy to address them. There are certain messages which have been posted in the chat. We'll address those also. And I think except for All India Institute of Physical Medicine and Rehabilitation, yet we do have certain OPDs, number of OPDs on mental health and psychiatry. And specifically, there is in the state of West Bengal, they've put in place a telestroke management network for people who get strokes. And this is also operational in hub and a spoke model. So this is a specialized telemedicine network which somehow has overlaps in today's events, objectives and scope. And they are doing it in a good way, that one neurological sciences hospital acts as the hub, and number of district hospitals in the entire state of West Bengal act as spokes. And in case a case of stroke comes up, they do the CT and immediately send it to the central hospital, neurosciences hospital is in Kolkata, and they get back the opinion as an emergency case in no time. So West Bengal is doing good, making good strides or significant strides in the domain of stroke management, tele-stroke management, and we'll be using all that information or rather experience in enriching eSanjeevani further. And as far as registration of health workers is concerned, since this is a government-owned platform, as of now, only the state, the doctors and the practitioners serving with the state governments are onboarded through the state health authorities by us. So that is the model that we are working on. And we certainly will be available along with our stakeholders here in the Virtue Care project, and will take further and stretch the boundaries of this domain. Thank you very much.
IFLU has been a strong advocate for persons with disabilities and inclusion. Can I ask him to, speak about accessing telehealth and virtual disability care for people with disability in India, potential and barriers. Thank you, Dr. Raj.
Such a, I would say, difficult time that all of them went through. And I was the one who was the most affected around all the number. And so we had no view as to what to do. And my campus where I live, where I work, was also shut down. And we move out. Even though we are patients and we are supposed to look for help and look for guidance in terms of getting the medicine, the approaching the doctor, or even reaching the hospital. So that was a very scary, very difficult time that all of us went through. And meanwhile, the condition was such that I was getting more and more vulnerable, I was getting more and more sick, and well, all of them agree with what you would have gone through. So that was a difficult time, I would say. And then what happened was, we are looking for help, and help wasn't there. So finally, somebody told my wife that we can approach a doctor over the phone. And that was the idea. And all of us know radiation is not there. So my wife took the phone and called the doctor, and she looked at me. She looked at my condition. She was instructing my wife my numbers to test my temperature and the oxygen levels, etc. And then she realized that my condition is so bad. And so she told us that I must be shifted to the hospital. Then in no time I was shifted to the hospital. There was no hospital which was willing to take me because hospitals were all full. And eventually I could get some hospital and I was there for a week or so. And the point I want to stress is that there's no help at home. And the only way that we were able to access it is with it. But in terms of how the opportunities are there, well, I can definitely vouch for the fact that Tele way of handling such a situation is definitely what all of us can look forward to. It will eradicate a lot of barriers and a lot of hurdles that exist at the moment. And for sure, as technology would improve, accessibility would improve, awareness would improve, opportunities will always improve. This is the way for the future. I can definitely say that. And as a person with disabilities, I was part of the state board on disabilities. I was a member of the board on disabilities. And after my experience with the COVID pandemic, we were able to get online and discuss as the board and start involving certain measures. In particular case, and then all the board members agreed that we should meet online, discuss things, and then come out with interventions, solutions and other opportunities by which we should be able to reach person with disabilities, especially. And so we opened a phone line, and we had about 1,200 cases, 1,200 cases referred to us through Tele. And we started to offer them various support. We started to provide them certain kits, and so on and so forth. So, using the telephone and all the technology that are associated with it is definitely what will certainly make a difference. And in terms of the future, how we can really negotiate it is the fact that somebody was talking about WCAG and so on. Yes, that's the way forward. We need to really comply to a lot of these norms and standards with respect to WCAG. And nowadays, more and more devices are also becoming dependable, affordable, and available. And so we need to also push for a wider deployment of several devices. I'm a person with disability. I'm also a university teacher, and I rely on a lot of devices, and which makes my life, professional and personal, extremely fruitful and functional. So accessibility is a very key. A lot of devices that are coming, and I think it's sooner than all of us, even as health workers and people from the world of medicine and so on, should really switch over to accessibility as fast and as quickly as we can. And as I can tell you, accessibility is always seen as something which would come in the way of the finances of it. And for sure, I can tell you that no, once if you include accessibility at the beginning itself, it doesn't add any cost. It doesn't add any cost. And the only cost factor, the cost factor would only come into the picture when you ignore it and only start thinking about it at the end of it. And that's where the cost becomes more expensive, prohibitive, and so difficult. So I would say that any intervention in terms of accessibility should come at the beginning itself. And studies say that, surveys say that accessibility at the beginning is cost effective, it's legal, it's moral, it's logical, it's technical, and it's so helpful to people with disabilities. And with this, I thank the opportunity for giving to me.
Okay, I guess we're all set. Good morning. Just about to get to good afternoon. Okay. This is it me to be with you. It's very accomplished medical practitioners. I am no doctor, and I'm not even a quasi-doctor. I've always thought I'd do some PhD and at least call myself Dr. Manjunath, but not there yet. But there is hope in life. So we will certainly find a way to get there. But thank you so much. Thanks for the institute and the organizers to giving me this opportunity. Just as a quick background, I'm with the Infosys R&D unit called ITETS, Research and Incubation Organization. Have been with Infosys for about 18 years. So largely, what technology do for any given topical area? And my area of interest has been in cybersecurity, over the many years been working on. So today, what I will try and do is to address remote or virtual healthcare that we've been working on, and how, and obviously all of you, I already found two ideas in this session. So morning there was a talk about a problem with lip syncing when you're wearing a mask, and how to solve that. And I have an intuitive way of answering that question. So that's one. The other problem is the accessibility on telemedicine, as in the telehealth advisories and how accessibility needs to be addressed. So we have a very sophisticated platform for we are not looked at it angle. Why web and mobile applications we have not seen it from the, which I think is a good idea. So I already have got 2 ideas from today's. I hope in my session today, and I've already been warned. So let me quickly get to the point. This is something that we in Infosys publish every 6 months on every different domain, understanding what are the most emerging areas that we need to be working. Look at healthcare in general. The fundamental aspects that we have seen are driving the next generation of healthcare are what's called the value-based care, the new consumer experiences or new interactions, digital front door, which is how the management of the patients, etc., happen. Digital and automation, I think we referred to it many times, how we want to bring efficiencies, and obviously telehealth in particular. Many of these, all of them are relevant. Motor healthcare, and all of these obviously need to have a slightly different color or shape when it comes to disabled friendly services. I think the few ones that I would like to kind of focus on today are around the topics where I've kind of tried to circle them with real time. How do we enable obviously with technology a certain monitoring of trends and their environment. With this, including their privacy and obviously security. Which can be used for just tracking an individual's heartbeat without the individual. How do we do that? Is something that we have worked on, and then identified technologies which can help. So the individual's privacy is protected, but individual's heart rate is monitored, so on and so forth. AI virtual assistant is another technology we believe will be very relevant in this context. We have done some work. If possible, I'll try and show it quickly, where both for language, limited language, even limited medical understanding. So how do we use an AI-assisted, AR-assisted technologies to help them take the right kind of medicines or follow a certain procedure, etc. We use for all of us. AI diagnostic assisted piece, I think, is going to be pretty much universal. This is something that kind of drives most of the new innovation when it comes to remote assistance, which is something that or tracking, say, physiotherapy. So people under physiotherapy and their movements, how do you understand the improvement in their ability to, move given the physiotherapy? That's one instance. You can think of it as similar to the, cerebral palsy, the kind of use case that you were talking about. The remote patient monitoring is the other one. We believe without necessary real-time and off-real-time remote monitoring of patients, we will not be able to deliver telehealth. And this remote monitoring, again, is something that we are looking at technologies which can be delivered through just a mobile phone. So that you cannot have sophisticated devices everywhere with everybody. So how do you look at just your mobile phone being that device for monitoring one's health? Then the affordable care and surgical medical support are slightly, I think, one step ahead. We are looking at newer technologies like 5G and how they can help surgical or remote assistance of medical delivery. But that, I think, is still a step ahead. The other 4 things I think are already here, for all of us to experience. The way we have gone about working on these topics has been the idea of looking at this patient-centric, use cases or applications. Obviously, there are these insurance, hospital, and regulators which influence the larger patient centricity and their applications. But we have tried to understand what are the key challenges that the patient needs to be, looking at to address, and how can we or how can technology help many of these use cases. The few ones that I want to bring to your notice today, for example, in assisted living, we are working on things around validation of quality measures. So today, any kind of AI algorithm or whatever that we want to use needs quality data for understanding and predicting health condition or a behavior of the patient. Now, there are a lot of limitations in our ability to get real-time or real patient data. So we are looking at how can we leverage simulated or synthetic data to understand a patient's behavior or a condition's behavior, which can be used to model your AI algorithms, which can then, in turn, provide assistance in developing the algorithms that you can, use it for monitoring and predicting the condition of patients. The other piece that I want to kind of refer to is on the community health. Here again, we spoke about limited access to health, particularly during challenging periods like COVID. And I'm assuming COVID was at least once in a century problem, and hopefully we don't have to, face it again. But nevertheless, the problems still remain. How do we look at remote patients who are not very well conversant with technology and be able to still engage with doctors and supports and caregivers. So we're looking at how you can use actually a television instead of a phone and use the television remote as the interaction device to interact with patients who are, let us say, a little oldish, they don't have an ability to are conversant with using phones and so on and so forth. So you can still use the television, which is pretty much omnipresent, and use the remote, which they are typically comfortable with because they have been watching TV, for assisting them in healthcare interactions. So today, because of that, you can immediately expand the healthcare access to millions of people who may not necessarily be having phones or conversant with phones. The other thing I want to bring to your notice is on the hospital ops. In fact, on hospital ops, as much as, I think we look at the efficiency on the patient side of things, if you have to scale for tens and thousands and millions of customers on the telephone, I mean, there is impossible to think that, there is going to be a doctor sitting behind in a hospital talking to a patient. That's not going to be possible because you have hundreds and millions of phones and millions of TVs all around the world, and people want, if there's a feature they want to kind of access a doctor, there is no way you'll physically be able to, have a doctor behind. So how do you create, let us call it an auto doctor behind this, behind the screen, who can understand at least the first level of diagnostics and assessments of the patient's condition, and then escalate it to a doctor who needs to pay attention to this patient, and not necessarily every call is taken by a doctor. So how can you have an automated doctor assistance, which is a lot more complicated than just, any tele support that you would have. Even today, a credit card tele support doesn't work fine, right? So imagining that if an intelligent system is able to do reasonably accurate diagnostics is kind of very challenging. That's another area that I want to bring to your notice as an area of technology which can assist scaling of all of this, healthcare that we need. I think I have spoken about this next-gen telehealth. The key technology we are working on in that space is, we have all seen many sensors for monitoring your heartbeat, fall, or monitoring your movement. We are looking at how do we bring multiple sensor technologies into one to interpret the condition of the patient much better, so that you're able to use your phone and then maybe a bulb, maybe some physical things that you have, all of them combined to understand the condition of the patient rather than one device that you think can answer all the questions, right? So you need to have a sensor fusion capability to get there. The virtual assistants, I think we spoke about. Remote patient monitoring also we spoke about. The X-reality training or immersive training is something that I think I will touch upon now. So one of the things that we have done, and maybe I'll just show a short video, is how do you use technologies like augmented reality to assist patient understand the medication or the process of consuming a certain medication or using a certain device, like in this case, taking insulin, right? So just by using your phone, you don't need to be trained. So anybody who just gets an insulin pen can then start understanding how to use this pen, right? So let me get there and we'll come back to all these topics if we have time. Let me see if I can play this. I think it's playing, yeah. So this is something that we had developed. Let me see if I can move it. Okay. I think you get the sense of this. So this is about using just your phone and getting an augmented reality experience or an understanding of how to use an insulin pen. Many people may not necessarily understand how to use an insulin pen, and there is no way you can physically train hundreds and millions of people. So this is something that we've been trying out to see if it can help, patients use such technology or such devices to manage their health, outside the hospitals. This is just an illustrative example. You can think of more complex situations, but this should give you an idea. The other piece I want to show you is from the, so I'll just take another 2 minutes then, yeah. So this piece is about how we are helping, or at least working on solving some of these problems. How does this work now? Okay. So this is about how are we helping hospitals manage large-scale remote patients. So again, like I said, remote patient monitoring, this cannot be done manually. So we are developing capabilities around automated way of analyzing all of this data and alerting the doctors only when it is necessary to look at a particular patient. So the question is about queuing, the question is about priority, what kind of disease, what kind of doctor is available at what time. So it gets kind of a complicated logistical situation for one to understand. The other is about here again getting the data of the let me see the data of the patient in one place. That itself is a challenge, and here is about getting data using your basic mobile phones of sorts. So we are trying to see how we can leverage the India health stack that you may have heard about to build solutions around very secure and privacy-led data sharing of patients across hospitals, which can then give a doctor a reasonably good understanding of the patient's condition with prior history, etc. And all of these are assisted, by the way. This is not just plainly putting up a certain dumb data in front of the doctor. It is about being able to have diagnostics behind it and giving lead indicators to the doctor. Hey, you know what? I've been able to analyze this X-ray. I've been able to look at this ECG. I think there's a problem here. Why don't you take a look at it, right? So it's all assisted capability that we're able to bring to the doctor. And I think finally, this is about even the engagement, right? So for example, this is showing how you're able to interact with the patient. And as you interact with the patient, is there something that you can read out of their facial expressions beyond what they are saying? So through facial analytics, we are trying to understand, just like the way a doctor may be trying to guess an overview of a patient's health, looking at the face or the behavior, walking or sitting. So we are able to do those kind of assessments as well. The last piece is, I think there was an example of this epilepsy thing being monitored that we spoke in the morning. So we're also trying to use this brain-computer interface devices to understand the brain activity, largely for human experiences and stress. I don't think we've kind of specialized it for specific disease of sorts, but that is something that I think we are quite happy to share. I think those are some of the examples that I wanted to share as possibilities where we have experimented, and I'm sure there's a lot of development happening around the world with these technologies. I believe AI, AR, VR, privacy, automation, and I think these 4 or 5 technologies will be very crucial for this remote healthcare. I'm happy to address any questions or discuss topics a little later in the day. Yeah, thank you so much. That was not bad, I suppose. On time. Oh yeah. Yes. Thank you so much. Yeah. Okay.
Thank you very much, Ms. Manjunath, for keeping to time and also giving a very exciting presentation. And I think this is more of a platform for not only sharing but a lot of learning. And thanks for also making it possible to pick up a couple of ideas. Without wasting too much of time, I'd ask Dr. Deepti Shanbag from the St. John's National Academy of Health Sciences. Apparently, we belong to the same fraternity. So, I have something which I've requested her to do is to finish a presentation in 12 minutes. So she'll talk about reaching persons with disability in rural Karnataka, Project Hope. Over to you, Dr. Deep.
Thank you so much, sir. I'll try to stick on to the time. I think from good morning to good afternoon, I suppose. So it's just 12. So good afternoon to all of you. I'm very happy that I'm here amongst all of you. A warm greetings from St. John's Medical College. I think you all know that it's in Bangalore, and it's a medical college with a 1,500 bedded hospital. And we are an institution which runs all the medical postgraduate courses as well as nursing paramedical courses. So we'll be completing 60 years next year. So which will make us to the elderly category. But yes, I've been in St. John's since 20 years now, did my post-graduation there. And now I'm also heading the community ENT and community-based rehabilitation. So this is a small experience which we had in a rural center, which I'll be very proud to present. And I also have to say that I represent my team. It's not my individual work, it's the teamwork which has made this difference. Okay, so I think this is something which is more of theory, which all of you know that the WHO definitely tells about the data management and deployment of technology for improving disability care. And the WHO Global Disability Action Plan specifically mentions about this. There has always been an efficient use of technology for chronic illness like tuberculosis and HIV, but I think regarding disability services, it is relatively new and probably mediocre. Research also in this field is probably lacking, and probably we'll have to take it forward with such illustrious crowd here. Sustainable improvements in provision of rehabilitative services has to be three-way, which is individual, which is basically rehabilitation plans, service provision level, which is services and processes, and finally the macro level, which is policy making and program development. So I'll be telling out two small experiences which we have with persons with disability. As you all know, India has 5 to 10, actually the census which was done in 2011 said that it's around 1.5% of the population. WHO says it's 10%, but it's probably considered the world's largest minority. So two experiences which I'll be telling. One is e-Punarchetana, which we started even before COVID started. And the second is the Unit of Hope application, which is basically tele-rehabilitation for children with disability. So what is this e-Punarchetana? I think the word Punarchetana basically means rehabilitation in Sanskrit. And this is the platform, this is the name which we adopted because it was meant to be for persons with disability. We have a health informatics division led by Dr. Tony Raj. And I had approached him way back in 2018 to get this done for the simple reason that few of the things which I couldn't do was lack of continuum of patient care. And I'm talking of persons with disability as well as eye and ENT patients, lack of coordination between community and the rural health center, standardization of data, which is very, very important for us, which we didn't have. Most important for me was paper storage. We had a lot of registers and a lot of place which we had to store. This project has been running for 20 years. So we had to store everything and we shouldn't miss out. So, but this was the important reason why I had approached our health informatics division to do something for our data, digitalize it and do something. And difficult to analyze data. It is only notes and prose which I couldn't analyze, which was collected by our grassroots level workers. Most important also was self-appraisal as a monitoring tool. Can we do something which can actually monitor the functioning of these health workers? Not that I doubt their sincerity, but the objective part of it was missing. So there came e-Punarchetana, which is actually has two wings. One is the hospital-based electronic health records. This is our rural center, what you see. It is 28 kilometers from St. John's Medical College, and most of my work is in this rural health center. And on the right, you can see this. Those are our community and some of them of our health workers. So it's we developed two tools. One is the hospital-based electronic health records. The second is the community-based data collection tool, which I'm going to tell you. So these were the two things which we developed as a part of e-Punarchetana. And I think these are the stages which is for anything and every software which is put in place. One is the needs assessment, second, designing solution, third, design iterations, training and launch, and finally, research and assessment. These were the 5 stages which we followed. And remember, this was from 2018 onwards, actually, which we started. So this is our eye clinic, which we run in our rural center. We have patients of around 60 to 70. It's a once-a-week clinic. And usually it's mostly managed by our health workers. You can see those ladies in saris are all our community health workers. So the challenge was to train them to use this software. So this was the needs assessment. The team, health informatics team, actually came to our center, had a lot of discussion with me and the health staff to see what are the different activities which happen and break those activities so that we can have a software based on that. So this is how they finally broke down the activities of just the eye clinic. So as you can see, those are the eye OPD which we have, and those are the steps which was involved in seeing the eye patient. So for each, we wanted it to be digitalized and we had to give up the paper-based data. So finally, the next stage was the logistics. Basically, who are the people who are going to do what, where's the money going to come from, which is the software we are going to use, and what are the processes which we have to follow. So finally, the training happened for all of our health center staff, the medical officers, the health workers who were quite keen to use this. Most of them have been there for at least 15 to 20 years. And we didn't expect that they were quite enthusiastic to use this software and were very, very keen to use this. So they had a training of at least 2 or 3 days. And finally, we went online, going live from February 2019. In fact, it was February 4th, which was the ENT OPD. And it has not stopped. We still use this software, the e-Punarchetana software in our ENT and ophthalmology OPD. So as you can see, this is how it goes. All the health workers, we don't use anything by paper. Everything is done through laptops and it is all connected up to the ophthalmologist. So everything is entered online, and this is a rural center. I'm not talking of St. John's Hospital, which has its own set of software. I'm sorry. So this is how a patient page looks like. It has everything, including diagnosis, treatment, even notes. You can even, each patient has a unique ID. We can actually upload their photos. We can upload any blood investigations, everything which can be done on this page. This is the ENT. So we have the same for ENT and Ophthalm. It's just that the ID is the same for both. If the patient comes for both ENT and Ophthalm, the unique ID is the same. This is, you can also generate data. All of the health workers who are 10 to 12 standard pass can actually generate the report. Some of them have been trained in our software so that they can actually extract the data. So we can see that from then onwards till now, we have 5,786 patients individual data, which has been entered with a unique ID, who have come only for ENT and ophthalmology problems. E-Punarchetana, which is the community-based, you can see these are our health workers. So we wanted to try the tab-based app so that they can go house to house and to screen for disability. That was the main intention of this community-based app. We had a lot of discussion of what should go into this app, what are the different questionnaires which we have to, because we had in plenty. And as you know, the first objective was to use validated tools. So this, apart from the initial social demographic details and the disability details, we also made WHO CBR needs assessment, quality of life, and most important, we wanted to geo-tag the persons with disability, and that was also put in this app. So this is the ComCare app, which the health workers have been trained in with everything, every detail which is being put. So as you can see, the ladies, again, there was apprehension whether these ladies will be able to come out of those writing notes, but they did come out. They were quite enthusiastic and they were quite tech friendly, in fact. And we have a set of 12 health workers with one data entry operator. All of them were trained in the usage of this way back in 2020. And the integrated survey started, which was house-to-house collection of data. And remember, this was the time when India was devastated with second wave. This was somewhere in 2020, from July 2020 to up to December 2020, we had done this data collection. And as you can see, every COVID precautions were followed, and the health workers didn't even hesitate to go to these houses. So this is the page, a screenshot of the ComCare, which I can access. All the data is available. If I want, the health informatics will help me in extracting the data. Like I said, my health workers are also been trained to extract data. This is the survey. As of now, we have covered 27,446 population with 6,550 households. Now, for us, I and ENT was the most important. And as you can see, disability is something which we had screened. We actually covered 553 diagnosed or reported disability. So these are some of the disability-related findings, all from the app, which was collected by our health workers. So I think it's not very different. I think the right side especially is something to do with the community-based rehab needs assessment based on the WHO principles. I'm very sorry. The most important, which for me was the geo tagging. So this is just a screenshot. You can see the blue dots. These blue dots are the households, and you can also see some of them are colored. Now these colored dots are households which has a person with disability, and each color denotes different type of disability. So you can see this yellow is actually, when I click on the yellow on the left side, you can see the details of the lady who's there in this household. Similarly, there's one, this is a purple, which I had clicked, and you can see that the left side, you will get the details. So we were successfully able to geotag every person with disability who were in our field practice area. This is one of the monitoring which I had told you about, number of households which were surveyed by the health workers. So that is about e-Punarchetana. Let me go to the next, which is the Unit of Hope app. Unit of Hope is a multidisciplinary team. Now I'll be talking more in the hospital-based data. So Unit of Hope is a special multidisciplinary team looking at children with disability in our hospital. And that's been functioning from 2004 onwards. Just like COVID hit the rural area, it also had an impact on children. I think Dr. GVS had mentioned about the OPD, which had just dropped down and nobody could come. So was with the children with disability. So what could we do? Can we approach them? Can we actually connect with them? So that is how the Tele Rehabilitation and the app started. So I don't think I'll go into detail because this has been told in detail in the previous sessions. What was the objective? To improve the access of children with disability to all the services which Unit of Hope team gives, which is basically medical to therapy to social work to counseling, and also to develop standard guidelines which can be inculcated elsewhere. It was funded by CBM Germany. So this was the timeline frame, and there was my bell also. But yes, so this was actually a project which started from October 2020, and it's going to end in September, actually. So it's a 2-year project, and it has gone through all these 5 stages. And finally, we went live I'm very sorry, I'm going to the previous slide, in February 2021. So the services, the app which was developed had to include all this, which was patient consent, assessment, medical treatment, provisional diagnosis, therapy, teleconsultation, counseling, and we were successful. And Unit of Hope actually said, we will not compromise unless everything has been included. And we successfully included all of it. And as you can see, this Unit of Hope app can be downloaded freely from Google Play Store as well as Apple Store. And you can see that the patient can be registered here. There is a consent which is there. And all these 4 aspects of tele-rehabilitation or services which I had mentioned has been put in this. So the different models, which I have to say is there are 3 models which you are following. The beneficiary caregiver directly to Unit of Hope, where a caregiver straight off connects to the Unit of Hope for a teleconsultation. The second is the beneficiary through health worker. Many of the mothers are illiterate or they do not have a connect or it's quite remote. So we have a health worker with a handheld app. She will connect to Unit of Hope and the parents. So this is the other, this thing. The third is through the primary health center, we have our own rural health center, the medical officer will connect the child to the Unit of Hope. So 3 models of tele-rehabilitation. These are the different services, and I'm just showing the screenshots of all the, some of the, notes of some children. So these are the intervention records, and you can see they're quite extensive. These are the teleconsults which are happening with various specializations. So you can see Dr. Maria was a pediatrician, physiotherapy, speech therapy, special educator, and MSW, all of them doing this. Then we also have a telecommunication where you can SMS, the patient can SMS and can ask some doubts. Okay, we also have a few videos and some health education materials, general as well as specific to the disability, which can be done. So this is the outcome from February 2019. We have 702 registered, 528 who are less than 18 years. And you can see we have almost done almost 4,000 interaction count, which includes SMS, notes, etc. These are the guidelines which we have developed for the tele-rehab. And that's the end of my session. Thank you very much. It's a very small experience, but for us, it has been a fantastic experience because the last 2 years, the COVID has actually taught us a few things for our own good. But I think tele-rehabilitation is something which will continue even after COVID. So with this, I thank everybody, especially Dr. GVS Murthy, Nathan, and Dr. Sarah for giving me this opportunity to talk. Thank you very much.
Thank you very much, Deepti madam. And I think, you've taken our advice very seriously in completing in 12 minutes. Thank you so much. And, you presented 2 very interesting, sort of initiatives which St. John's National Academy of Sciences has sort of implemented, and you've also learning from those experiences in terms of both in e-Punar Chetana as well as the Unit of Hope. That the government of Telangana, as a matter of fact, has a large database called Sadara, which was developed for a different purpose altogether, but has been used extensively. Maybe you can have a look at it as well. Can I call upon my very good friend, Anthony Vipin Das, to talk about the iSmart database, portability of data across the health system. And Vipin has been actually spearheading a lot of initiatives at the LV Prasad Eye Institute, who have been at the forefront of using technology in patient care and as well as comprehensive patient care include rehabilitation. Over to you, Vipin.
Right. Good afternoon, everyone. Thank you, Dr. Sharman, and I'd like to thank the organizers, including Dr. Murthy, for having us here today. I'm Dr. Anthony Vipindas from the LV Prasad Eye Institute, and for the next 12 or so minutes, what I plan to do is just to tell you the journey of a data point and what we've been able to do at the LV Prasad Eye Institute. So I represent the LV Prasad Eye Institute, which is a network of 263 centers spread across 4 states of India. As you can see, the eye health pyramid takes us all the way down to the rural village level. Patients get referred to the primary eye care centers, to the secondary eye care centers, the tertiary centers, and the Center of Excellence, where I work in Hyderabad. Over the past 12 years, we spent time digitizing this entire massive eye health pyramid, and we've crossed 1 crore patient visits last year. We are in about 7 countries, about 3,500 users use the system every day, and about 10 to 11,000 patients go through the iSmart system as we speak. So currently we are in India, Nepal, Dominican Republic, Liberia, Cambodia, with implementations planned in Mexico and Zambia. So the data point has got a few characteristics, right? So more importantly, we're talking about volume of a data point, velocity of a data point, of how frequently it's generated, the variety of the data point and the veracity of the data point. But more importantly, we are talking of value, right? So all the 4 V's get generated, but then we are more importantly trying to understand how do you derive value out of all of this. So the possibilities with data, yes, there's clinical data that gets generated. There's media, there's financial data, and also operational data that you will use for looking at patient efficiencies. Of course, the challenges is, as one of our colleagues was just mentioning in the previous presentation, quality data is lacking, right? We need to generate good quality data, and more importantly, continuum data. It can't be something in a time point like a retrospective study. It is time dependent, and also standardization of collection is an issue across different geographies. I put this out in a perspective piece in the IGO this year. But we've done descriptive studies, diagnostic studies, predictive and prescriptive. These are the spectrum of possibilities that you can do with data, and I will show you some examples as we move on. So coming to the eye health pyramid, right? So as I said, that data gets generated at each of these levels. And how do you ensure portability across the geography, right? So as we speak, there are people being seen in the rural community guardians, in the vision centers, in the Center of Excellence. So this is a snapshot of what happens in the tertiary center. This is where we basically have, the most complicated patients who basically come in for care. Of course, as you go down the pyramid, the digitization kind of flows down to the secondary centers across 4 states of India. I love this picture I took a long time ago, where I actually show a community guardian transitioning from a book onto the app that we basically developed for them, and including Mr. Venkataya, who basically was the first one in 2016 to start the community screening on the tab. And also we basically collect a lot of data of eye images, of course, because eye is an external organ. You can basically take wonderful pictures of it. These are our vision technicians who basically capture all of this information. We have Tele-Ophthalmology that goes in on a daily basis. And more importantly, we're able to identify people who are not able to come, but who require care. And we're able to deliver that information immediately. And we use 4G SIM cards, and we use Skype, which is free. You don't need satellites and stuff and everything. Innovation has to be simple. The other thing that I wanted to basically understand with respect to data, HKMBT, 100, 1,000, we are now in the million, but can healthcare talk in terms of billion and trillion, while all the other, financial sector, social media sector, they talk in those, metrics. So we basically published our first 2.2 million understanding of the iSmart in the IGO a few years. And currently, this is our kind of base cohort. It's about 5.1 million. It is growing as we speak. But our whole goal is for the country, can you actually lay down foundational work of understanding what is the presentation of ocular disorders in an Indian cohort, right? You all read the textbooks. The West has this, Europe has this, India, big question mark, right? So our stepwise approach is basically to get good descriptive papers, and also not just that, we've kind of classifying all of this called as the AI project. You can go to ResearchGate and probably follow our work there. But I'll show you some examples like dry eye disease, a large paper in 21,000. We looked at risk factors. We also looked at geographic distribution of pterygium, which is an external ocular condition that develops because of exposure to sun. And not just clinical diseases, we're also looking at outcome, which is value-based care, and not just cataract surgery that we all know in ophthalmology, but highly complex surgeries like scleral tear repairs, traumas, evisceration, orbital fractures. Because the data is there, we are putting our experience out. And not just that, we also kind of visually represent, because you can only do as much of figures or tables in your paper, right? So we also use interesting visualization tools, which basically allow you to do multiple combinations, right, of the similar data set for you to basically look at an understanding. One of the things that's very close to my heart that we did was setting up the eye care services in Liberia, which is a country in West Africa that's ravaged by civil war. Dr. Rao, our chairman, was invited by the President Sirleaf to kind of help out with setting up the eye care infrastructure. And we did that in 2015. And today, Liberia lights up with data on iSmart. Basically, people have an understanding of all the different counties where patients come from. And also what is the most common is not cataract, it's refractive errors. COVID, of course, brought a very, very interesting challenge to all of us, right? And we've been quite busy. The first thing we had to do was set up our telehealth apps. We built Connect Care, which was for the urban population. And we also launched home care. So essentially right now at LVP, we are now able to go and at least assist people who are not able to come to the hospital, right? People with disabilities, they're not able to travel. There is a dedicated home care team that is now traveling with the basic equipment and is able to transmit that data to the main EMR at the base campus. And not just that, as I said, we've been busy putting out our experience because it's a once in a lifetime opportunity, right? I mean, to basically understand what are those vulnerable populations that are getting left out because of the challenge of the pandemic. So we put out a lot of our experience in patient presentation, teleconsultations, surgery, diabetic retinopathy, endophthalmitis, infective keratitis, keratoplasty, strabismus, a lot of other papers, but most importantly, you can see most of them expedited publications because the information had to go out in time for people to know, people to, kind of act on it. So just a kind of how we've kind of looked at pre-COVID, lockdown, and unlock how different diseases or patients presented. We also looked at different geographies, out of state, intra-city, intrastate, and international. We also looked at percentages of drop of patients coming in from all across the country to us, both in terms of pre-COVID lockdown and the unlock phases. And not just that, we also looked at when did we recover, to the pre-COVID levels. And a lot of this was basically looked at because then we found out who were the vulnerable populations. Definitely, there were women, there were children, the elderly, people from rural, and people from out of the city. All of them basically dropped significantly. And not just that, on the geography aspects, we also looked at where did we recover from the tertiary centers to our secondary centers. And surprisingly, we recovered much faster in our rural level as compared to the tertiary care. But also, more importantly, we're talking about data. When you look at EHRs or EMRs, one of the most important aspects is structured versus unstructured data. Today, we all kind of grapple with that, right? More importantly, you need good structured data for you to have good insights. So iSmart, at least 70% of the data is very structured. It's something we're grateful that we did it 12 years ago. Today, we are reaping the benefits. Unstructured data, yes, most of the clinical findings are there, but you can use NLPs and even basically text mining to basically understand the same. I want to bring to your notice this pipeline that we published a few years ago. More importantly, is to kind of set things in perspective on how we approach AI and ML at LVP. So step one is you need to digitize with EMR. You can't have paper written notes that will get scanned with OCRs and then expect you to understand patterns, right? The second aspect is build a good EMR. Don't build a text box. Right? Just don't put everything into a text box and then say, oh, data is not structured. The third is where the whole world is publishing, right? So they take sets and say, oh, our AUC curve under AUC is this much, our sensitivity, specificity is this much, but you need to bring it back into the EMR. You need to bring that insight back into the EMR. You need to quantify the usage. Why will a doctor basically use an insight that is being told by a machine as opposed to decades of experience? And you all know that clinical validation is the final nail on the coffin. You have to ensure that in the real world space, how do these algorithms and patients, and then what you learn has to go back to retraining your model, right? So this is what we've kind of over the years understood and what we follow back home. We were also grateful. We've received a Welcome Trust grant to work on this. And of course, with Dr. Murthy as being a key collaborator to us, he's a great guide and mentor to us. We've been working on public health, big data, and health economics specifically. So on the health economics front, we're looking at value-based care, like, the Ayushman Bharat, that that's one of the largest national health insurance policy launched anywhere in the world. But if you have a pot of gold and you have to give it to, say, 10 people, how do you decide who deserves what, right? You will run out of the pot of gold very soon if you don't kind of have guidelines to basically know how do you prioritize, who basically gets priority for reimbursements. So we are basically looking at understanding gender disparities of care. More importantly, we found that women were actually less insured, they were paying less. And also at what time point people were also kind of spending what in their lifetime. And we have also been working very closely with the NICE International in UK. So the National Institute for Health and Care Excellence. This is the guideline body of the NHS in the UK, and they are working with us closely with the IHOPE Secretariat to create a few guidelines for India. So NICE is actually training us on how we set up the whole process of creating guidelines for the country using real world data. So more importantly, I think we've all entered this era where we basically have to understand that there are many, many factors that go into how patients respond to treatment. And more importantly, keep an open mind and just learn. There's nothing like a set assumption when you head on into a study. You're looking for patterns. And more importantly, let real world teach you what those patterns are. To hopefully, get to value-based care in the future for our country. So with this, I'd like to say thank you. I'm on this email. Happy to, get your comments and feedback. And thank you for your patient listening.
Thank you very much, Vipin, another V, who spoke about volume, velocity, variety, value, and veracity of data point. So please allow me to add another V. Thank you very much about the iSmart database. I think it's wonderful in terms of what you have presented. And let's go on to the next presentation. Can I request Dr. Arun Zakaria to present about the learnings from COVID-19, new and inclusive virtual health education at CMC Vellore. Thank you.
Thank you so much, Professor, and thank you for the promotion to doctor. I'm not a doctor. I'm a IT systems manager for education technology at CMC Vellore. Thank you for the organizers, and it's really a privilege to be here. As you know, many of you know, CMC Vellore is an old and large tertiary care center in Vellore, South India. And during COVID, we actually did a lot of new things in addition to the large patient load and teaching that we already undertake. And I just wanted to share a little bit on the healthcare education side at our institution. Okay. So we did several teaching programs, and then one interesting support line that we actually had during the COVID period, both in wave 1 and wave 2. In a very short time, we had to do training for people, not only medical practitioners, but non-medical personnel all around the country and across the world too. And with the help of technology, we were able to, within like 2.5 weeks, of course, we have really strong faculty on campus and educators, and we were able to create multiple courses, not only for medical practitioners, but also for non-medical people. And with the support of Tata Trust and Azim Premji Foundation, we were able to actually train thousands of doctors and non-medical professionals around the country in a very short time. And for this, we used blended learning. Those who are in education or education technology understand this very well. It's a combination of asynchronous and synchronous learning, where we provide learning material and content to the students beforehand, and then we come either online or actually face-to-face for synchronous learning. And we were able to use several different things to create this in a really short time. We use some industry standard learning content creation software, and we were able to create a workflow where we'd have the academic team create the content in a simple manner. We would go on to a technical person who would actually put it in a format that was readable for them. We'd go back again to the academic team, and before we would publish it out on a platform. And we had to quickly use various cloud services. We didn't have all the infrastructure in the institution at that point. And then we also found out immediately that there were health workers and non-medical professionals who didn't even have access to a computer, and they didn't even have access to internet all the time. So that's where we built an in-house app, where it was a mobile app and also a web app, where you could log in once and download all the learning content, and then at your own pace, at your own time, without the need for internet, could finish learning all of that. And all along, we used a learning record store to capture a lot of data, including every button click that the student would take and every assessment the student would take, and collected all of this data in a large learning record store, where we could then use reports and visualize it, not only for the students to immediately tell them where they lacked or where they need to improve, but also back to the educator saying that your students are not doing too well in this assessment, or they are actually listening to this video many, many times over, and then why would you do that? At the same time, all the content, wherever, especially the video content, we made sure that there was subtitling, and wherever possible, there was voiceovers, because we knew that people accessing it would have, we need to be included in all forms. There's still a ways to go for all that learning content, but it was something that we really learned well at that time. So we used a open source platform, which is available. Open source is you don't have to pay for the software, but you do need your own servers to run it. So we would be able to quickly create a login for a medical professional or a non-medical professional in the course, and they could just register online, and immediately they'd get a login and a password, and they could start accessing the learning content. The academicians were very clear that there would be separation between the what they would share with a non-medical person, especially drug usage, and a medical professional. So we had to keep that separate for the two different kinds of students that we were dealing with. And we used modules like this. This is actually made in Articulate, which allows self-learning for the students. So they could actually go along with their own pace and finish up the modules. And then they would have once a week or a couple of times a week an online interaction in Zoom with the actual professor who wrote the module to ask questions or then facilitate discussion forums and so on. And each of these modules has assessments built right in, so the student can immediately assess themselves. And in a typical classroom, you take a test and you won't know if you got it right or wrong till the exam's corrected and returned back to you. But here's immediately you could see not only know that you got it right or wrong, but also know what the right answer is. So there was this immediate learning right then and there. And additionally, you could do it as many times as you wanted. So you build some sort of mastery by being able to do this in this manner. We had the integrated short course. Again, we had like question banks, which we had really start in a short time. We did even a ventilation course just for the doctors on campus. So we had that too. And then we also did this very unique course for non-medical professionals. And we made it available on the desktop, on a website, and also in a mobile app. And so they could just go, you had to still register for the course, but you could get access. It wasn't at any cost. It was funded project. And the other thing that we were able to do well is translations. And that's one huge part in including people, because even some of our medical professionals, their thought language is not English. They do know how to speak and read and write, but when it's given to them in Hindi or Tamil, we did Marathi, we did Kannada, just the needs from these various states were. And with technology, this becomes really simple. We had the English module, then you pull out the English text, we would get machine language to translate the first round. Then we'd have a medical professional whose mother tongue was that language to read it. And then we'd send it to another doctor to just, or a nurse to review it before it was published out. So literally in a span of a few weeks, we were able to create these courses and really help share learnings. Of course, there's a long way to go now, especially Google and Microsoft Translate. They're doing really well with Indian languages now. So it's not like a few years ago where it was, most of it was a disaster. Not so anymore, but still really important for a medical professional or a nurse, or a nurse too, who is a medical professional, to go through it before you publish it out. And behind the scene, we constantly gathered the data. And we used existing tools like Power BI to create reports all the time. And it was really a learning thing for us to understand where to put our effort and where we need to change things around in a really short span of time. And we were able to train doctors. So on one side is all the various, this was through Tata Trust that we did this COVID training. So their hospitals and the government hospitals are all included here. And then the various trainers. So we had the trainers and the trainees. And you can see we were able to cover most of India there. Additionally, we did the non-medical people, which was just community of health leaders and so on. And now we've moved on to training community health officers with a program with NHSRC and the Gates Foundation. So with all of this, just wanted to share one last thing. We did a helpline during the wave 2. And this really had a tremendous impact on the local community. We had an automated phone line where they could choose Tamil or English, and it would direct them either to a medical professional or to a social worker if they had a particular need. And anecdotally, we captured so much information that we can't even leave the house. And because then we were able to send people not only to provide medical care, but also basic necessities like food and so on. And as Dr. Vishwarupal also suggested, that the phone line was a really important thing, because we forget how many people don't even have a smartphone. They just have a feature phone. So for them to just pick up and call and hear a message in their own language, and then to answer, to talk to somebody makes a huge difference. So with that, just a really short thing, I wanted to just leave with that. We see a lot of potential for telemedicine, tele-rehab, and along with that, online and tele-education. It's still it's still something where you still have to touch your patient, you still have to learn those skills, but so much more can be done, especially for postgraduate level or for areas where you cannot reach at all. This is really a wonderful opportunity, and we really hope that some of the learnings we have, we can share, and we're happy to discuss anything with if anyone has any questions. Thank you very much.
Thank you very much, Arun, for a fantastic, sort of overview of all the educational sort of virtual health education at CMC and its application across the board. At this point in time, I just wanted to let you know that Dr. Sara Varghese, Director, CBM India Trust, is present online, but she has very gracefully acknowledged the fact that we need to have a panel discussion and have more discussions around things which she would have presented, which has already been presented by a couple of speakers here. Thanks, Sarah, for allowing us her time to also convene this panel discussion. I would request Nathan to describe Nathan. I think I should say Nathan is an Indophile. So that suffices. Nathan is professor at the University of Melbourne School of Population Studies, and also a senior research fellow, and has been, I don't know if you hold an Indian passport, Nathan, but has worked extensively in Nathan and has been a very close friend. And the youngsters here, I would request you to look up something called as Photo Voice, which is something which Nathan had proposed long time ago, and it's a very interesting tool about how we use it in disability studies. Thank you for that, Nathan. Nathan will do will moderate the panel discussion, but at the same time, can I request Prof to occupy one of the chairs, and Mr. Rajshekhar to be accompanied by Dr. Murthy, Manjunath sir, Deepthi ma'am, Vipin, and Arun. So I've requested Nathan to also moderate the panel discussion which we missed in the morning, as well as the panel discussion scheduled for now. And hopefully we will not delay your lunch. Thank you very much.
Okay. Good afternoon. Thank you for your attention. Hoping to keep on my convenient minutes. It's been an amazing information today from experts around Australia, around India, around the world. I'm overwhelmed by the amount of patients we've seen between 50 million from Tanzania and from Vipin's work. It was 5 million, 270,000 a day. It's going to be numbers of huge. So I think that we can learn a lot from each other. I want to spend this time just to learn from each other and think together what we can do in the future. And then we have a chance to go in the room this afternoon to have more discussion. Let's talk ahead and more discussion this afternoon to think through how we can move forward together. So thank you all for your input already. And I want to start by asking a question about research. And then I'll take questions from the floor and from the Zoom call as well in the chat. So firstly, all of this work is done, the work that the organisation done involve research. So in terms of making patient healthcare more inclusive, what more research can you be doing and what can we do together? It'd be great to have with a number of organisations or many of them. What can we do in making disability accessible virtual healthcare? Research.
Maybe I can have a first go at that. I think it's important to do good evaluation as we go, and particularly, I guess it's very attractive to the idea that people with disability will gain greater access through digital platforms. But I think we have to be very careful that they're not missing out on some value of care that they would have got through face-to-face interaction. And that we don't end up in a situation where, yes, we're covering a lot of people, but perhaps there's certain groups that actually get worse care under that scenario. So I think careful evaluation of programs is the way to, looking at particular both groups would be the way to tackle that. If anyone else wants to buy in.
Yeah, adding to what Mike said, I think we need to also promote a lot of research in the area of telemedicine. This has already become a reality, and we should also have various ways to kind of analyze and assess how telemedicine is making a difference to the individuals at the grassroots level. And the other point that I want to mention is about the use of accessible medical aids and devices. WHO has already come out with new guidelines and modules for ICT, and these are very easy and not so complicated modules that companies can come forward and try to implement them in the design stage itself. And as I spoke already, if accessibility is considered at the international stage itself, at the initial stage itself, it makes far easy for any product to be available right out of the box to be accessible as such. And many companies have to really consider persons with disabilities as another potential market for business. 15% of the world population is considered persons with disabilities, and companies should have to consider there's a lot of business out there, even among persons with disabilities. They should not think in terms of whether they buy or whether they can afford it or not, but certainly they should also look at persons with disabilities as a potential market. Or else 50% is a huge market that no company can ever afford to miss. So this is what I'm going to say.
Thank you. I just want to add that we need to be mindful of what our current situation is. So about, I'd say about 7-8 years ago, we introduced a small button in our system to say, is this for a patient, someone with a different ability? And then we are trying to capture that data. So now people are actually looking at all the people who presented to us, right? What kind of eye care problems that people with different ability have. But more importantly, that would give us further questions to ask, answer, look at where they're coming from, level of visual impairment. I mean, speaking from an eye care perspective. But I think we should capture, there should be a start somewhere for organizations to be able to put it into the case sheet or the history. And then that will be a great starting point for us to really, at least in the population, what are we looking at and answering. So in that way, that would be a first step for us.
I just also want to add that in India, our database regarding persons with disabilities is minimal. I think each of us have our own database, but there is no uniformity. So with this, can we have something which actually has a standard form? And through virtual health, can we have a kind of registry which is existent for other diseases? For example, cancer has a registry. So can we do something like that? Putting our minds together, maybe improvising what we already have as a software for data collection. Can we put it together and that can be research by itself, because I think research on persons with disabilities, I think you all agree that it's not much. So I think that is something which we can do.
Thank you. Thank you very much, Cynthia. Thank you to the other speakers. One thing that does come through the data is getting data from people with disabilities, but also, as Dr. Shak had said, how do we hear the voice of people with disabilities as we start investigating this area in our research? I need to start at the planning stage, at the delivery stage. Now that's what we're doing with Virtue Care, is actually researching and co-designing with people with disabilities. That'll be more about this afternoon. But I really appreciate that. We need to disaggregate data. A number of people also asked about getting access to the presentation. We're producing a report after this, which will give access to all the registrants online and also virtually, by face-to-face. We had over 300 registration. So that's why it's been very, very complex to manage all the technology. So thank you for your patience online and also in the room. We will get a report and also the presentation, the video is available on today and make that available to all of you as well. Any questions from you, from the audience here? There's a few online as well.
Very quickly, I have a comment and I have a question. One, I did hear everybody's about the barrier to vaccination, and that's a huge barrier for our disability. And ma'am, you're very valid that we don't have enough research. And now the Indian and the global definition of disability is now 21. So where are we going to start and how much are we going to do?
Thank you.
Okay, I'll start from the last question, which is the 21 types. Yes, we do have 21 types of disability, but at least let's start with the 7 basic types. Let's start with that. That also we don't have the data with that. Let's start with that, and then move on to hemophilia and other, other disabilities which has been listed. But I think the basic is something which we can always add on. Other disabilities. I think at least something to start on is what I think it is. As far as barriers to COVID vaccination, I don't know whether the question was intended for me, but I will add, yes. So in our rural area, yes, we ask everybody. In fact, we have every health worker have been allocated 3 or 4 villages. They are multiple health workers, and one of the questionnaires which was given to them was, ask if these people have been vaccinated, not how to was asked, and it is special emphasis on disability. And if you find that there is a person with disability who has not been vaccinated, we try to counsel them and get them at least to the PhD or get a vaccine to them. Because at some point, vaccination needs to be delivered, at least to the village level. So that is what we have tried our best so that all the persons with disability have been vaccinated, which was not something which I listed, but yes, it's something which we have done.
Just make a comment that in Australia at the start of the vaccination program, people in aged care and people with disability were prioritised for vaccination, and yet it went very poorly for people with disability. It wasn't organised and done in a structured way. And so that certainly, there can be intent, but you need a system and you need dedication to make it happen. It didn't happen in Australia.
How could technology have improved the access to vaccination? People with disabilities vaccination?
Part of the problem is who are they? And how do you find them? Aged care was a bit easier, and that people were in a residential aged care. But even in residential disability care, the rollout was poor, and it wasn't the problem back then, really.
So I think this question again came back to how technology can be used. So coming from the background, and I also want to kind of elaborate on the previous question that you had about how can we collaborate. See, me coming from a commercial organization, and most of you are either with hospitals or research universities, I think there is a huge complementary interest. Like Mr. Rajik was saying, 50% of the population, is a big market. And today, as far as I know, I think disability is also one of the key objectives that corporates want to address as their goal. So there is significant pull on the market side for addressing every product need to be accessibility, both because of regulation and also because of intent. But I think the supply chain of sorts is broken. For example, we were trying to develop an accessibility product,
which can actually test any ICT product for accessibility. Now, we can't test it fully intensively because we do not have access to disabled people who could actually test it, in person of sorts. We had two people who we had recruited and they were part of our employee base, but that will never be scalable. So if we can figure out a model where organizations like Infosys or any other organization can have a very seamless collaboration with research institutes like the ones that we have here, and like we do clinical studies of sorts, right? We can actually have our applications used, tried out, or tested by the people in your or the patients in your network. It becomes an easy way of trying to develop new products easily, and also the disability people will get a better solution, over a period of time. So I think there is a reasonably good motivation for this collaboration to happen. And to the technology, I think for every problem, at least we are trained to think how technology can help. So even for example, there's people with disability, like I was talking about how we were trying to use this remote and voice assisted conversation with patients who may not be able to write or who may not be able to move around. That's, I think, it's a very simple but still accessible, not an expensive technology available, where a TV is actually interacting with the patient or whoever you want to call in assisting them. But there was a simple thing like reminder for medication. Hey, this is the time. Please take the medication of sorts, right? And then you use the remote to accept or reject that particular advice. So these kinds of technology interventions, even very small, will make a big difference in helping people have a quality of life.
Thank you, Manju. I think a lot of the ideas that you've all presented, we've seen those ideas used in some sort of context somewhere, but one of the questions in the audience is how do we scale this up? How do we make it a reality? We've heard the potential, I think, this morning, but how do we get it to reality on what we're doing currently?
Yeah, let me. Is Android online? That's right.
I'm not sure if Sanjay is still online or pursued. We might keep it to the panel here, rather than the way we get short.
See, like every solution that we have looked at, including, for example, during COVID time, a lot of industry organizations got together, building a solution that could help organizers or government to manage the COVID situation better in terms of getting better awareness of where the infections are happening, where should the emergency responses should happen. So all of that happened in a very short period of time amongst many companies that got involved. But the question of scale was always there. And I think particularly in India and large organizations, every idea, every solution is looked at as a scaled solution that needs to be developed. And today technology kind of reasonably enables scale. I don't believe technology is an impediment anymore for scale. It is about our ability to make it available at scale. The only challenge can be a commercial model that will enable us to support such a scaled solution. I don't believe technology is a limitation today for scale. So if we can figure out a reasonably good commercial engagement, either with government or people or consumers or whatever, then I think we should be good with the scale solution.
Thank you, and when I will also,
if I just may add from my viewpoint, technology certainly is an enabler and scale. But before that, education about rehab, about differently able, like every primary care doctor, every primary care nurse has to be made aware of this in the first place. We do hear so many stories anecdotally out in our network and even at Velo, with a basic understanding of what is needed for a differently able person for rehab is not there. Even our primary care doctors are not aware. So more of that should be happen. Selfishly, we have started one course now, a postgraduate diploma in rehab medicine, where they're trying to connect primary care doctors and workers together. It's a 1-year course. I think we need so much more. And then what the various institutes are doing around the country here, just really need to scale that up. And all alongside, technology can enable, can join in. We probably have an opportunity to start with technology right at the beginning. So I think that we should certainly be considering.
Again, for somebody else in the panel, but the second part of that question was, the second part of that question was looking at the reality of people with disabilities and how do we scale up those services to people with high needs using Tele rehabilitation. Also address that particular question.
Sorry, could you repeat the question again?
Okay, yes. So scaling up is one thing, telehealth for everybody, but how do we scale up telehealth for people with high needs, have disabilities, who have difficulty accessing, seeing, hearing?
Yeah, thanks, Nathan. At least I'll tell you the experience what we've done at LTC during the pandemic and first year, because we have our set of patients who could not come to us. We were easily able to call them. And as a matter of fact, rehabilitation was the most used during the period where Dula and her team basically were able to reach out to the patient pool that we cater to. Question is, what about the patient pool that we don't cater to, right? Again, as I said, when we talk about technology, it is not an ideal scenario that one solution is all there. It is not one, right? It maybe is the responsibility, collective responsibility of academia, private hospitals, public hospitals to use, as ma'am mentioned, standardized way of capturing information. So yes, we were able to serve patients who were, and of course we have a rehab helpline that we've been running for many years now. Aishwarya and Priya are on the rehab helpline. And rehab helpline, we've kind of, again, tried to get that out as much as possible out into the population through various means. And we do get calls, and that slowly kind of increases the database of data. Not just from our catchment area of the 4 states that we cater to, but across the country. But still, again, that kind of database helped us to truly reach each one of them, whoever requires some sort of support during the challenge.
I think for children with disability, in fact, scaling up will be not probably be a little more complex because a child with multiple disabilities, like cerebral palsy, for example, requires assessment by multiple people. If everything can't be in a virtual mode, there has to be a physical assessment. Somebody has to touch the child, talk to the child, and assess before we go on to virtual mode. I think the first assessment has to be taken. And if a team like Relative Hope, which is there in St. John, can do the assessment, the rest of it can even happen on television. So that is what's happening now. Now, COVID has stopped. We don't have that many COVID cases, but the tele-rehabilitation still continues. And we know that children with disability require tele-rehabilitation. COVID was actually a boon because we started the tele-rehab. Otherwise, probably we have gone. So I think initial assessment is a team which can is good. And actually, if I have to say, St. John clearly might train a team like that, which is similar to Relative Hope, which we have done before. And probably even have the Relative Hope app, which can be used for tele-rehab. Yeah, that can be done. And then stay with even the ComCare, the community-based e-punerchidana platform, which can be very good. So we can train them, we can scale it up, and Geo Tagging 80% will disability. Shouldn't be a problem.
With regard to scaling up, one of the areas that we also need to acknowledge is the fact that there's a gap between what happens among PPOs, I mean, disability people's organizations and research organizations and other foundations, for example, deposits, etc. So there's a lot to have that. But this has to be easily bridged. Technology has given us so many opportunities. Social media is one area related to most of it. WhatsApp is a good area. People are very well connected, much better than ever in the past. So I think we can optimize that and scale it to that.
I'll just add one thing. If something scared me today a bit was seeing the incentive for seeing a lot of patients via telehealth, and I guess complex cases of people with disability who require longer consultation, perhaps there should be built into systems an incentive to spend the time with those complex cases rather than speeding through to get you 500.
A pediatrician spends an hour. The initial assessment she does, she takes an hour. That is on a one-to-one, which definitely can't happen on a daily rehab board. So I think that's something which we have to take care of.
I think that it's come again more the panelists, the importance of having a guide or someone locally to be able to help in some of these more complicated disabilities. My daughter had a wheelchair fit yesterday, and she has multiple complex disabilities, and they had someone zoom in as well, one of the technicians, and someone came by. It's very hard to do a wheelchair fitting without having someone in the room. So there's limitations to the way we can work with telehealth or with virtual healthcare to assist them. Thank you. There's one question from the room and then one more on the Zoom call.
It's been a great learning experience. This is Dr. Symposium from Vaccination, which is I think one interesting thing, especially from Dr. Sharma, that's what she's told us about. I think the whole opening up of digital health and telemedicine because of COVID opened many new doors, especially in the country like India. So we have such a huge rural and tribal hinterland where accessibility to medical care is so difficult, and especially for the disabled. And I think the conversation that is happening here can open up so many new frontiers and doors for those people who are doing a tribal hinterland of India. So, all across the globe. What we have noticed is we work on early identification, early detection, rehabilitation. In the last 2 years, for example, we lost a lot many cases, especially for even challenged. Don't have an opportunity to even travel for these speech therapy or therapies. So, forget about those cases which are in the urban areas, which also have lost the opportunity. And there are many of these sort of last mile connectivity issues. For example, all of these, maybe have even lost children because of lack of time. So, what question that I have is, apart from the, especially the larger group which is organized in this, there have been some wonderful softwares and digital platforms which have showcased, especially in terms of child assessment, eye care, and many of these aspects. But is there other platforms, especially across the Australia, India, and other parts of the world, to work on things like last mile connectivity? We have a lot of virtual interfaces, but then technology where over the last mile connectivity, especially when delivering some of the physical needs of the disabled. And this we have seen that it plays a major role connecting the disabled to the health system. Another question that I have is, have you also you spoke there are many other small organizations or entities which have designed such platforms, which even we have, for example, for Nidus Hospital in Hyderabad, India, brought down the rate management document, which have small enterprises which have done the smaller, especially in some areas. So does the scope of the study also have, trying what sort of
As a panel person, and come back to answer the question about the study we're doing this regards. We'll be engaging with literature this afternoon very widely, getting inputs from different models and examples. So if you know any more, please in touch with us. The other question was the panel.
Okay, I don't know, I think I'm getting the wrong place. Absolutely. Okay, I don't know whether I have a straight answer for you, Dr. Santosh, but the last connectivity, yes, in the Telerehab app which I mentioned, there is a scope of SMS or even a call which can be done to a coordinator. So what there is a coordinator for this thing who can be connected, and there have been instances where children have been sick, and especially during lockdown, when they have actually messaged my child is very sick, what wants us to do, and we have actually responded immediately, telling them please go to the nearest health center which is, and we have in fact suggested, let's say if they are from a specific city or a specific village, we have even suggested which hospital they can go to. So that we have done through the Telerehab app. But not a very concrete what you said. So I mean, I don't know whether this answers your question, but I've tried my best to answer that.
Professor, just to add to what Shyam mentioned, is that I think each organization or body has a responsibility to be sensitive to be able to at least tag people who are accessing. At the scale that we're all talking right now in the country, the only major player who has access to the kind of last mile that you're talking about is the government, right? And we've all used the largest app so far, at least that I've used in my lifetime, is the Covet app, right? But it's the only app that we've spoken which was used by literally a lot of the people across the country. But I can't recollect a question that asked me whether I had it or not. It's an opportunity lost. So the point I'm saying is that if you're able to deliver services, I mean, through the e-agility or any of the other aspects, are you basically sensitized enough to be able to capture it and then have services, technology solutions catered? And again, I completely agree. You cannot do everything virtually. It is impossible. Maybe follow-ups or maybe at least information that is pushed to these vulnerable groups could be an option in the future. I think it's just that conversations like this should reach policymakers to be able to include it as an opportunity that should not be lost, but should be utilized for the benefit of all.
Maybe just from the Australian context, I think the last mile for us, the big piece of that is addressing health inequity in our Indigenous communities, many of whom live remotely and have very poor health and difficult access to care. So there's probably a lot more that we could do in connecting the community health centres in those communities with our much more centralised specialist care services in a much more organised fashion than we do at the moment.
So, again, I think both this last mile connectivity and scale, I think both are also interconnected. And while medical care is so individual centric, so person centric, you cannot obviously do it all in remote and all in technology, like many people said. But I still believe that if at all if you have to scale, if at all if you have to go to the last mile, technology is the only answer. Digital technology is the only answer. We may have to find some slices and dices of which will help. For example, early diagnosis or early detection is something that you will not need a doctor to sit down and diagnose every piece of the patient, touch and feel the patient to understand it. In, let us say, 80% of the cases, if not 100% of the cases, right? So I'm very confident. I've spoken to many startups
across the country, India, and elsewhere. There are a large number of healthcare focused startups coming up in the diagnostic space, in the post, say, surgery or post-event care case. I'm sure each of those will be able to address some slice of the problem of the patients. I think the only thing that's stopping them is the affordability of these patients to pay for something like that. If there is a mechanism which can support them for large scale adoption, then the commercials will fit in. I don't believe that will be a problem. And not just startups. I mean, look at Google, look at Apple. Everybody is behind them. So I believe the last mile problem, the scale problem are being addressed today, even without, it will be addressed without significant human intervention. Technologies like AI, like computer vision, like later on quantum computers for medical discovery, etc., will play a role in solving this problem.
Just want to add one more. Sorry, we have to finish up discussions. Sorry. One comment. Probably just like robotic surgery, we could have robotic physio, robotic those sort of things in future, and we put and make it sustainable.
I agree. I think also what we've said, the technology almost exists. It's a matter of how you use the current technology. Get that last mile. I think you do.
I'm just going to leave you with two thoughts that I did here. One was barriers and specific specific barriers that people would have to face. And the second one was the impact that you want to take. I think it was a brilliant panel and there was so much that came out. So I just thought I would share with you.
Thank you. You've done my job. So thank you. I really appreciate your inputs. There's much more discussion happening after a really time right now, but most of speakers are staying for lunch. So feel free to go and grab them and ask particular questions that you might be able to get more information. I'm really all happy to answer your questions. Thank you very much. I'll hand it over to the Chair.
Thank you for the time. I think it's my pleasure to invite Professor Michael Wesley, Deputy Vice Chancellor International, the University of Melbourne, to give us some summary thoughts about the morning session. Over to you, Mike.
Thank you, and it's been a fascinating morning. Now, let me preface my remarks by saying that I'm learning quickly that one of the things that a Deputy Vice Chancellor is expected to do is to sum up after sessions that he knows absolutely nothing about. So let me preface that my remarks by saying you all are much more expert in what's been said this morning than I am. Let me just make a few remarks. I'm not going to, I realise that I stand between you and lunch, so I'm not going to try and summarise absolutely everything that's been said, but let me give you a few sketchy impressions of what I've heard. First of all, this is an incredible project, and I think it's testimony to not only everyone who's involved in the project, but one particular person, and that is Nathan Grills, who's, I think, a one-man NGO. He's a scholar, he's an activist, he's a practitioner, he's a fundraiser, he's a lobbyist, he's just an incredible force of nature. And if this project hands out as all of the papers that have been given this morning suggest, this is going to make a transformative impact in the lives of people who really need transformative impact in their lives. So this morning, we've listened to presentations on remote care, on accessibility, on eye care, on training, on a whole range of different aspects of what this project can deliver. What I've been hearing and what I've been thinking as I've been listening is that India is well placed to be a real testbed for innovations of this sort. It is a country with a lot of people, and it's a country with a lot of people with disabilities as well, and a lot of people with access issues and who face struggles in gaining access. It is a country that has technological innovation as part of its lifeblood. And I think the willingness of the Indian population to experiment with new forms of technologically enabled access shouldn't be underestimated. There is a huge amount of health data that is available in this country. And as Frank Kateria and I were talking about in the car this morning, a huge amount of health data really does power up things like artificial intelligence and makes artificial intelligence. I've also been thinking about the comparisons with Australia. As Mike Mckerbin said in the panel discussion, Australia faces its own challenges. It doesn't have a huge population. What it does have is remote populations, particularly Indigenous people, that really don't have proper access to healthcare, that face really serious issues of disability and really serious issues of access as well. I think also in Australia, I think about the issues that surround our National Disability Insurance Scheme and anxieties, and very real anxieties in Australia about access and affordability of the NDIS as well. And just thinking of the possibilities of virtue care and other technologically enabled access to disability care and what that might do to the NDIS. There are many questions that I'm left with. I have to say, as a non-expert, it does strike me that there are parallels here between what virtue care is trying to achieve through technology for supporting and providing care to disabled people, and what we've just gone through in terms of the pandemic and the shutdown of university campuses, where we had to pivot very quickly and deliver education to tens of thousands of students very quickly, many of them in remote locations and offshore as well. I do have questions about scalability. I know we heard a lot about scalability on the panel, but I wonder whether there's a little bit of techno-optimism going on here, because ultimately it would seem to me that there always needs to be a trained human being at the back end of all of this technology. And I do worry, I do wonder about whether, as the technology scales out, whether we will have enough properly trained, properly skilled people at the back end of the technology. I also wonder whether if this is too successful, could it end up being perversely isolating as well? So, that we default to the online option rather than making sure that we provide people with access issues to face-to-face care and face-to-face consultations. And finally, I do wonder about access. I wonder about people who are less comfortable with technology, less trusting in technology, and what some of the barriers might be as well. So look, I'll leave my comments there. It's been a fascinating and rich discussion. I do feel privileged to have been part of it, and I will be watching virtue care as it develops in the years ahead with a great deal of interest and optimism. Thanks very much.
Thank you for that reality check as well, and the challenges that we all face as we go ahead. Thank you. I wanted to thank you and Dr. GDS to present you a book. The book is from Srinath Reddy, the director of the HFI, founder of the HFI. He's soon to be retiring, but I'm looking forward to reading it myself. This is short something you can read on the way back on the flight. Someone's also been down a chair today. It's been a big job to get into such a busy program in a short amount of time. Thank you. Appreciate the Dr. Shimana for a long time, so we thank you for your input. And I just want to thank all the speakers again and all the participants as well here today that have come from a long way away, many of you. Thank you for your patience in getting through the session. I really hope we have some more discussion over lunch. And to thank you to those people who have joined us virtually and to also due to technology, we're learning as we go in terms of virtual care and virtual technology. So we look forward to learning more in the future. Thank you all again and to thank our presenters for joining us.